Bore da a croeso I gyfarfod bwrdd iechyd Prifysgol Cwm Taf Morgannwg. Hoffwn I estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the bi-monthly meeting of Cwm Taf Morgannwg University Health Board, which is held in public. We are broadcasting today's meeting of the board live, providing the opportunity for anyone with internet access to observe in real time using a link that was shared via various channels prior to the meeting. I would like to therefore extend a welcome to all who may be observing the meeting today. A copy of the video of the meeting will also be available following the meeting on our website for anyone who wishes to view it. In relation to today's proceedings, I'd like to note the following. Colleagues will be aware that we continue our commitment to ensure we conduct all board business in an open and transparent way. Live streaming our board meetings has been well received and allows real-time access to all of our stakeholders to observe over the internet. Whilst we continue to provide this facility, we are keen to return to face-to-face meetings of our board. We therefore continue to explore opportunities to enable us to achieve face-to-face meetings whilst enabling some remote contributions through Teams and live streaming. For those observing, firstly, various of the reports being received today have previously been scrutinised by the board's committees in the weeks leading up to the board meeting. An example of this would be Integrated Performance Dashboard report, with relevant aspects of that report being scrutinised at CTM's Quality and Safety Committee and CTM's Planning, Performance and Finance Committee. The scrutiny afforded by board committees is set out in highlight reports prepared for each board meeting, which are listed under our consent agenda items. Secondly, you may notice that board members and other presenters may not always be looking at the camera. This is due to colleagues needing to reference their board papers throughout the meeting. And thirdly, we will be taking a very short break during the meeting after about an hour at around 11 o'clock and possibly again at 12 o'clock depending on the timings. For board members, firstly, questions on the consent agenda items have been sought in advance of the meeting. I can confirm that no questions have been raised in advance of the meeting. Secondly, as referenced earlier in my introduction, where it is evident reports have received significant scrutiny at board committees, the board will take this into account when receiving this item and therefore the amount of time focused upon it. Thirdly, as part of the steps we take to seek to continue to improve the work of the board, at the end of today's meeting, I will be asking colleagues how you think we have done. There are some question prompts set out in this regard at the end of the agenda. I encourage all board members to keep this in mind and offer reflections and suggestions in this regard. All board committee chairs have adopted the same approach after each committee meeting. For presenters, when introducing a report or giving a presentation, presenters need to take into account that board members will have read the reports in advance of the meeting, and hence the board will only need to be made aware of any issues that may have changed since the report was drafted. I would like to welcome Gillian Day, Health and Wellness Programme Manager, who is here to present the listening and learning story on the Wellness Improvement Service, WISE programme. Sarah Fox, Head of Midwifery and Gynecology, and Mohammed El Nashati, Care Group Medical Lead, who are both here to take part in the presentation of the Maternity and Neonatal Programme report at Agenda Item 5.6, and Sarah Thomas, Deputy Director of Public Health. I have been advised that the following people are observing the meeting today via the live stream. Lucy Jugasur, Internal Audit Manager, Sharmala Govindasamy, Programme Engagement Manager, Public Health Wales. Apologies for absence. We've received apologies from Carolyn Donoghue, Independent Member, Mel Jehu, Independent Member, and Lisa Curtis-Jones, Associated Member. I go on to the next item and declarations of interest. We've not been notified of any declarations of interest prior to the meeting. Has anyone or have anything they wish to declare at this point? Wendy, has anyone noted any other declarations, please?
Nothing further declares, thank you.
Okay. I then go on to item 2.1, which is the listening and learning story. I am pleased to invite Gillian Day, Health and Wellness Programme Manager, to present today's listening and learning story. I invite Gillian to say a few words before she shares a presentation of the work being undertaken by the Wellness Improvement Service WISE programme. Gillian.
Hi, good morning. Yes, and as you said earlier, it can be a little bit intimidating to present a board, so apologies for any nerves on my part this morning. So I've got a little video to show you of a piece of work that we undertook with Cardiff University to help us produce the actual programme. So there's a massive element of co-production in the work. So if somebody could just show the video first for me, that would be great. And then I'll talk you through where we are at the current point with the programme. So the next slide has got a link to YouTube, Dan. Okay.
Wasn't in a very good place at the time. I'd recently been in hospital and very, very ill. My mobility had gone downhill anyway. My daughter found on the internet about the course and said, "Mum, have a look at it and see what you think." I was apprehensive, I'm not going to lie, I was. But it's been very positive. The help from the staff and the members of the class has been brilliant. It really has been brilliant.
The idea of behind WISE is about looking for solutions to people with long-term conditions that are non-medical. One of the priorities is for us to look at social prescribing that actually might be more successful at managing their condition.
You know, people just think of the GP, the doctor or hospitals consultants, that's the only route. And I think perhaps we need to look at other routes to help well-being and, you know, help people.
I'm a registered mental health nurse, so I'm very passionate about looking at alternative ways of people being able to manage their own condition independently. It's not all about the medication and all of the other medical treatments we can do. It's about giving that person a fulfilling lifestyle, really, and looking at that whole holistic process to health and well-being.
So these workshops we're offering through WISE gives people an opportunity to taste a range of art forms. It develops personal skills such as self-confidence, being able to relate to others, to share thoughts and feelings.
We were given these little exercises to do for the chronic pain management part of the course, like distraction techniques, the breathing, because I used to have panic attacks.
I knew what I needed to do. I knew I needed to exercise more. I knew I needed to look at my diet, and they enabled us to formulate an action plan. I think it's made me focus on what I need to do to help myself.
Well-being is something that people are becoming more conscious about, that it's an important part of their lives. There is some evidence coming through that people on the WISE programme have made quite significant improvements to their lives. The sleep has improved, the diet is improved, and some people have lost a considerable amount of weight, for example, and that's improved their mobility.
I would definitely recommend the WISE programme to others. I was really isolated before the programme and I was really down and depressed, and the programme has fetched me up my shell. And it's kind of boosted me up a little bit, which is good.
It helped with my emotional state, my mobility, my understanding of how to cope with things, just generally in life.
It's been quite amazing. It brought me back from a dark place, and I am grateful, very grateful.
Lovely. If you can swap to the next slide, please, Dan. Those participants were all willing participants, obviously, and consented to the making of this video and undertaking the piece of research as well. And I will just add that 3 of the ladies who spoke have lost a combined total of 15 stone between them at the moment, where they are on their journey. So for us, I'll be as quick as I can. I am a very fast speaker. Those of you who know me will remember. So in Cwmtaf, we have approximately over 114,000 people sitting on waiting lists. This waiting list is continuing to grow and will continue to grow over the next couple of years. We know that. Next slide, please. Of these people, 1 in 3 of them have got a chronic health condition. So we have 1 in 5 people on a waiting list, and then we have 1 in 3 with at least one health condition. Next slide, please. So the programme was set up. We had a GP with a special interest in wellness medicine. She had a very productive conversation with Paul Mears at the time and the execs, and they luckily supported the development of this piece of work. We had a tiny investment in primary care previously for self-management, and it grew into this programme. So the aim is to reduce the risk of people developing problems on a waiting list, to improve their symptoms, to make sure that self-management becomes the basis of all treatment, and that people understand that it's not just about a medical model to care. And to then, our long-term aim is to reduce the flow onto secondary care waiting lists from primary care. Next slide, please. So this is undertaken by, we have 7 coaches, or we will have 7 coaches. They deliver group sessions. They are supported for a period of 18 weeks, 18 sessions. This is done flexibly, can be done virtually, and it's at the person's decision really. It's agreed with them how it works. It's delivered right across the health board, anywhere and everywhere we can afford or get a venue, it's delivered in it. There's the resources are made and developed for people with a really low reading age. So we were really clear that we want people to be able to access it regardless of ability. So the resources are suitable for anyone who has, you know, whatever need they have. And it's in a variety of sources as well. So from the start, patients are taught, participants are taught to be responsible from the first day they come through the door. So they are taught to measure their blood pressure, taught to think about what they eat, to think about their well-being, and to score these so that we can measure it to understand how we're impacting on their health. So we take measurements at 3 intervals to understand that, and that's what we're in the process of doing at the moment. Our current capacity is 5,500 people a year, but we've just refined the model, which can increase that to up to 8,000 people a year from April. So there's a massive element of social prescribing, arts, anything really, making people more connected with their communities, because this is the issue. People aren't connected, they're isolated, and that's the biggest thing that we're seeing with people who are coming through the door. So there's a large element of the programme is how to connect people with their communities. We're constantly looking for volunteers within the service. The basis of the programme is that volunteers can be involved in the delivery of it, and we have a number of them, and we aim to continue to grow that bank of volunteers. Next slide, please. The next slide. Lovely. So we've got some initial outcomes from the programme I just wanted to share with you. So pain patients are one particular group that we're taking from our waiting lists in the health board. Other patients, they're mixed referrals whilst we're developing pathways. So our initial outcomes from patients at the moment are 95% of the people who have undertaken the first 2 assessments have increased their physical activity scores. We've got a system that sits within our GP systems that scores people's activity. The same, 100% of participants having an increased well-being score, 95% have improved their blood pressure, and an 80% reduction in weight, and an improved BMI as well. There's a couple of comments off patients in there that you can see as well, just about how they feel about the programme. Do you want to slip to the next slide for me? So for us, this is where we're going in the future, really. So we're awaiting confirmation of funding for the next financial year to know what we can deliver within the service. So we're currently looking then at how we can support the clinicians and our communities to understand self-management. It's a massive change of process for people. So this is our aim for the next year, really, is how we work with these people to do this and not automatically go for a waiting list. So we're going to do a large amount of community engagement around that large scale change. For us, speaking to you today is a really good opportunity because you are change makers. You know, it has to come, it's top down, bottom up, this approach. It's massive change that we're asking for, to ask our clinicians to do, particularly, you know, when it comes to risk, people do worry about these type of things. So, you know, we need the support of the board for this also. We're currently redesigning the pain waiting list to improve access to services quicker as part of this work. So it will allow by the spring patients to have far quicker access to the right treatment at the right time. And it should make a huge difference to current waiting times. and it currently has, I won't share that data with you today, but we've got a lot of data about how we're impacting on the pain waiting list. We're doing the same with, as I say below, the orthopaedic waiting list as well. We're working with them on knees and hips alongside the rheumatology programme also. We've also agreed to deliver a dementia programme from the spring, funding providing obviously, as long as it exists. And that's a really exciting opportunity for us. It'll be the first time in Wales it'll have been delivered, and it'll be for patients as they undergo their memory assessment. As soon as they're diagnosed, them and their family will be able to be offered the same kind of support as everybody else on coaching. So another part of the work is to work with our partners to train them and to train their staff so that the messages are the same. So we're working really closely with several mental health providers at the moment who are going to be undergoing the same training as all our team, because for us there's no cost involved in getting these people trained. So it's about consistency and the same messages then across the whole of the patch. So that's a massively important part of the work for the next year. Do you want to slip to the next slide for me, please, Dan? So this is a gentleman who was on the pain waiting list. We have got a lot of patient feedback, in fairness, and the impact of, and I think it's really important that we understand that, and you as the decision makers also understand what people think. So it's just that for this gentleman, it has had a huge impact for him, and it is quite a simple process. It's cheap, and you know, why not? And the next slide. And that's me done. So I can't see hands or anything, but because apparently you can't. I'm not sure if anybody does have questions, but I'm open to that, and I hope I've covered it as quickly as I could, and I've made clear what the service does achieve.
Well, thank you for your presentation, Gillian. I'll just invite members to raise any questions should they wish.
And we'll read.
Okay, if I could invite Linda in, please.
Yes, thank you, Emrys. First of all, Gillian, I just wanted to say you have no need to worry about your nerves with that presentation. It was absolutely brilliant. Thank you so much. I feel like completely inspired having listened to what you've just been talking about. I think my question is about, first of all, to say you've said we are the decision makers and we can help with this. Well, I would love to be able to do that and say, obviously, from my personal perspective, you have my full support because I think it's an incredible service. My question would be really is, what's the potential of this service? You talked a little bit about some of the things that are going to happen. I really fully support the dementia part of it and everything. But, you know, if you had a magic wand, what would it take to really deliver an even greater service? And do you feel you have the ability to be able to define that and then ask for the money and you know, because I think it'd be great to see more of this.
Yeah, I think it's a difficult situation because we need to show the outcomes to show something's working. But what we're ultimately seeing at the moment is the validation process we go with patients and the conversations. There's two different levels of this work. There's one level where you're having a brief intervention with a person and signposting on, and there's the one where they need a more sustained support. So there's huge, I can't emphasize enough. Yes, it's going to grow, change, and become something that people need and want for our communities, particularly. And that's the vital part of this piece of work. But for us, we've spoken to the Assistant Chief Exec of NHS Wales and had a really good conversation about what it looks like. It is a bit of an exemplar from a sort of spread and scale approach. I've started working with Hywel Dda and Betsy about how they can start utilising it, because all this needs is they band 5 posts and band 4 posts. They're not skilledly, but in that respect that they're an allied health professional, it's an easy post to recruit to. I've got one vacancy now that I shortlisted yesterday. I had 47 applicants. I'd say 30 of them were good quality. That's unheard of. You know, I've got band 7s out that I can't recruit to. So for us, it's a really easy post and service to scale up. And because the other health boards were in a very different position to us in that they've got far more of those things that we utilise within WISE, such as the app store that we have a behaviour change app. A lot of the other health boards had those things and have them already. So all they have to do is pull them together. So for them, it's really far more straightforward than us. However, that's going to be a far more straightforward process. For us, there's a bit more to unpick around waiting lists, around how we can support those waiting lists. It 100% can be done. There are professional boundaries that can become barriers, and I think there's a large amount of work that the last year, that's all we've done is try and support and break down these barriers, and I think that's how it all gets pulled together really at the moment. Let's not work against each other, let's work together. Yeah. Thank you, Linda.
If I could invite Paul in then, please.
Yes, thanks, Emrys, and thanks, Jill. That was really inspiring presentation, and great to see this project really starting to have an impact. And I guess there's some questions, I think, for us. So if you think about our ambitions as a population health organisation, this is absolutely tuned in to that, isn't it, in terms of trying to avoid people going into sort of clinical intervention, medical interventions who could be managed in a different way. So there's a definite value-based healthcare angle to this. And I suppose the point you've made about scale is really important, because I think if this is already proven to have an impact for some of our patients. The question for me, I guess, is, and I'm sure Bethany might want to comment on this in a minute, is how do we make this almost a routine route for people? So if their GP thinks they need to be referred for a specialist service, if there's no, if there's any conversation about it or debate about it, they should almost be referred into the WISE service as almost like an interim step to assess with that individual. Do they really want the intervention they're going to need, and B, is there an alternative way we can deliver that for them, which isn't needing them to go and see a specialist? So I think there's definitely something here about how we scale it, but linked to that, I think, is the point about how we really quantify the benefits, because you've described some really positive patient benefits there, and individually, clearly, that's had a massive impact for those people and their condition. As you'll appreciate, the challenge is how do we do this at scale to make the impact at scale as well? And I think that's the conversation I think we need to probably have with you and Lisa and others about how do we start to really ramp this up and think about how we can evidence the clinical impact, the waiting list impact, and also the financial impact in an era where we're going to a really challenging financial climate. So how do we use these sorts of alternatives? But I think it's a really fantastic route, and I think there's also, I know you've presented to the community partnership work that Natasha's leading on, but the opportunity to engage our community groups, volunteers in our communities, to get them almost take this on as a peer support. I mean, Emrys and others, we talk about MySteg later, but the opportunity to develop a model like this in MySteg, which was very loud and clear coming out from the engagement we did with colleagues, patients and communities over there, is huge. So I think it's a really great opportunity for us to put this as front and centre of our strategy. So thanks for your efforts, because I know it's been a big old piece of work to get it to this point. So thank you.
It is a bit, and for us in primary care, we're redesigning our prevention activities around it, so it'll be an umbrella service that covers all our other activities as well, so that it's easy for patients to understand.
Thank you. If I can invite Gethin in, please.
Thank you, Gillian. Sorry, my computer's running a little bit slowly this morning. So thank you for the presentation. It really reminds us, doesn't it, of the value of these services. And I hope that we'll be able to confirm the funding for next year imminently. So
before I leave,
give us a few more days, and I'm very hopeful that we'll be able to at least get the clarity for next year. I think the challenge that it sets is that it really changes the focus, doesn't it, away from a very medicalised model of healthcare to a service that supports patients. And we had a really good discussion about it at Operational Management Board yesterday about how do we think about all our services. What do WISE do currently, which you do exceptionally well? What are the things that we can help WISE do in the future, and bring some of that specialism into WISE, but very much seeing it as a supporting our population to live well themselves. And then how do our more secondary care services then fit into that in a different way. But again, very much seeing, as Paul touched on, that real interface for many of our services between primary and secondary care. You know, pain has just been a huge positive story, hasn't it, in terms of poor patients waiting an exceptionally long time for interventions, where we've been able to support them to live really positively, and how we can look at roll that out across both physical health conditions, but also around our broader mental health programs, absolutely has got to be you know, clear part of our strategy for services over the next sort of 12 to 18 months. I guess, and you know, when you start to think about different specialties and different services, you know, there's a whole area within women's health that we can probably look at how we can do that, as well as a range of our chronic conditions. But just a massive thank you to you, the team, who've done an amazing job in mobilising this and generating such a positive impact. So thank you.
Yeah. So just to say about the women's health, we have got meetings in place to start a pathway for women's health patients on the waiting list. So that's in place, and to see if we can do lifestyle interventions for them.
Great. That's brilliant. Thank you.
Yeah. Thanks.
Will I invite Sarah in, please?
Hi there. Am I on?
You're
Great.
on.
Thank you, and congratulations, Jill, that this is a fantastic piece of work and brought together lots of sort of discussions and sort of aspirations over many years, I think, hasn't it?
Yeah.
You know, and I just would echo, I guess, everything that's been said already, but I think the most important thing is that what you're doing here is looking at needs through the patient lens.
Yeah.
And, you know, that is about what's important to them and what matters to them, rather than perhaps what we might otherwise be doing, which is a very medicalised model, which as Gethin referred to just now. So yeah, so very well done and fantastic to see some data coming through. I just wanted to perhaps add a slight addition to this, was that conversation I was in last week with CMO, Chief Medical Officer, and the public health leadership team across Wales, and they were talking about the Minister's interest in prehabilitation, and we brought WISE into the conversation because actually I think WISE offers more than just a sort of a specialty specific rehabilitation, because it has that ability to align across all aspects, because people don't just have one condition, they don't have just one issue, and being able to look at the person as a whole is quite key to success, I think. So I know you've already had those conversations, but I think the Minister will be tapping on your shoulder as well to learn more about this being an exemplar for the rest of Wales. So yeah, it's great to be part of that. So thank you, Jill.
I know it's you know, it's a disappointing time for me, because obviously I'm leaving in a few weeks' time, so it's a hard one, but I will continue to support and push this work from my new place as well. So I know it'll continue to grow. But Sarah, I think when it comes to prehab, it's a huge opportunity around prehab. Again, it's about breaking down those barriers around the specialisms, but there's a massive opportunity here for that across the health board on a far different scale. Yeah.
Great. Thank you.
Thank you.
Wendy, can you confirm if there are any remaining questions or any objections raised, please?
There are none, Chair.
Thank you. I'd just like to say a big thank you, Gillian, for a really inspiring presentation today, and certainly enabling us to have a greater understanding about the promotion of physical and mental well-being. It's and listen to colleagues' comments, you know, and from what you've shared with us today, some fantastic work going on. Well done to you and the team, Gillian. So thank you very much, and it was great to see you come to the board and present that with us today.
Thank you, and thanks for your time, everybody. Thanks.
Okay, thank you. If I could then go on to item 3, please, which is the consent agenda. To ensure we focus on business, critical activity and discussions, we continue to use the consent agenda for this meeting. I'd like to remind everyone that highlight reports from board committees are routinely included on the consent agenda for formal noting and are placed on the main agenda for discussion only when there are specific areas identified in the report for escalation to the board. I'd also like to remind colleagues that many of the items on both the consent and main agenda have already received significant scrutiny by our board committees prior to being put before the board today. It is important to note, therefore, that the level of discussion and debate at the meeting today is not a representation of the totality of time and consideration undertaken in relation to these issues on behalf of the board under the board's scheme of delegation and committees. Given colleagues will have had the opportunity to read all the items placed under the consent agenda in advance of this meeting, are there any issues that anyone wishes to move to the main agenda for discussion, please? Wendy, can you please confirm if there are any colleagues raising any questions or any objections raised to any items on the consent agenda?
There are none, Chair.
Thank you. I therefore propose that all members present are happy to approve and note all items as requested. I could then go on to item 4.1, please. Are there any matters arising not considered on the action log? I've had no call on matters arising. Is there anything from you, Wendy?
No, Chair.
If I could then go on to item 5, which is the integrated governance, performance and assurances. Can I call in, I invite Paul Mears to highlight the main items from the report, which is for noting. Paul.
Thanks, Emma. So just a few items to update colleagues on. Obviously, my report talked about the pressures we've been experiencing over the past few weeks, particularly Christmas and New Year period. And I'm sure when we come to the performance report, Bethan will touch on that. But just to say, a huge thank you, I think, to all of our staff who've worked so hard over the past few weeks, dealing with the huge surge in demand that we saw around Christmas and New Year in the first couple of weeks of January. Pretty unprecedented, really, I think, by any of our experiences of demand that we've seen to date, largely caused by a combination of continuing COVID pressures, high levels of respiratory illness and flu, all coming together at the same time, obviously, as the well-known pressures and challenges we have around discharging patients out into the community. So a really big thank you to staff, because it has been really, really difficult for people, not just in our hospital services, but across primary care, community services, mental health as well. So just wanted to say thank you to all of our staff who've put in so much extra effort over that period of time. Colleagues will also know there's been a big focus within Welsh Government on the challenges around hospital discharge. There's been correspondence in the past couple of weeks from Chief Executive of NHS Wales, the Chief Nursing Officer and also the Minister around discharging, to try and encourage as many people as possible to be discharged. To reassure board members, all of those conversations have been had with our clinical teams based around clinical risk. So we've been very careful to make sure that whilst we've continued to focus on promoting discharge of patients when they can go, we are also making sure that that is done on a risk-based basis. So we are not discharging people that we will then see coming back in as readmissions. So it's been a big challenge, as colleagues will know. The number of delayed transfers still remains high. We're working actively with colleagues in all three local authorities to see what we can do to improve that. There's been a great deal of support from the local authorities to try and achieve improvements in patient flow, but I think we need to recognise that there are still significant numbers of patients sitting in hospital beds who are waiting for packages of care or care home placement. So that pressure, whilst the demand pressure has abated slightly in the past week or so, we still have significant pressure on the discharge end of our pathway. Obviously, also the pressures around demand and activity have been compounded by the industrial action that's been had. We've had a combination of strike action before Christmas from the RCN, the continuing strike action from ambulance staff, and also now CSP, Chartered Society of Physio. And we've also had notification about the Royal College of Midwives strike dates, as well as further strike dates from the RCN and the ambulance service. So continued day-to-day management of those situations when they occur. Again, very proactive handling through our gold command structure, and also great work from our operational teams to try and make sure that we maintain service provision where for our essential services. And the positive dialogue that we've had with the unions around derogations has been really helpful in terms of making sure that we can continue to provide core emergency services for patients when they need them. I'll just come back to escalation in a minute because I'll ask Matt to update on that because he's been working on that. Just to also highlight that a couple of other areas, board members will know there's been a considerable amount of work underway at T Clyddiad over the past 18 months, really, to try and improve the quality of service that's been provided at T Clyddiad. There have been a number of reviews of that service undertaken from national bodies and also WISC, the Welsh Specialist Services Committee, who commission our services from WISC. Really pleasing that WISC have agreed to de-escalate T Clyddiad from level 4 escalation, which is their highest level of escalation, to level 3, with a roadmap now to move down further down the escalation ladder in coming months. Lauren Edwards, our Director of Therapies and Health Sciences, has been the executive lead for T Clyddiad and supporting the clinical team there with their improvement. But again, I just have to say a big thank you to all of the staff in T Clyddiad who've worked really hard to address some of the issues that were highlighted, to really focus in on how we improve the service for the individuals there, listening to the patients and their families about what's important to them, making sure they've got the right structures, governance processes, quality assurance processes in place, which has resulted, I think, in the improvement in the escalation status. So a really positive story there, and an ongoing, I know, program for improvement that continues. And also just to highlight, so finally, that we had a positive couple of days up in Maesteg last week. One day in Maesteg and the second day in Caira, talking to the communities up there around what they would like to see developed in terms of health services for their community, and particularly what they would want to see in the planned redevelopment of Maesteg Hospital. Really positive engagement with a large number of people coming to our sessions, giving some really positive feedback and interesting feedback actually about what was important to them, not just about health services, but also things that had an impact on their health and well-being, which has given some really broad insights now into what those communities are looking for from their local health and care services, which will then help shape how we develop a programme of improvement in Maesteg. Many of the things that were highlighted actually aren't going to need loads more capital money or big projects of work. It's about coordinating existing things in a better way for our communities in the valley up there. But lots of opportunity, I think, to continue that really positive work with a number of key stakeholders, patients, community groups, local politicians. So really great to see that engagement, and I think a model that will give us a model of engagement, that will give us a design that we can take and use in other places to really get underneath what's driving people's ambitions around their health and care services. Also, just to highlight finally in 2.3 where we are on our escalation status. I don't know, I'm just bringing Matt. Matt, did you just want to give a brief update on where we are with the conversations with Welsh Government now about the escalation process?
Yes, certainly. So just to focus on what's changed as of the back end of last year. So enhanced monitoring, I'll start at the bottom there with planning and finance, and that's all around being able to produce an approvable balanced 3-year financial plan. In terms of quality issues, and that's specifically relating to performance and more specifically around waiting times, we're also linking that critically into our transformation programme of work. And then, of course, maternity and neonatal quality governance, leadership, culture, trust and confidence remains in targeted intervention. So we've gone back to Welsh Government and we have reviewed the terms of reference with them and the framework, and this is really focused now around de-escalation and a closeout plan for CTM to get us back to routine arrangements. So we've got the first quarterly meeting coming up on the 9th of February with Welsh Government, the escalation team, and what we're doing at the moment is taking that framework that we've agreed with Welsh Gov, and we're developing that into a programme of work to understand the gaps that we've got. So this is taking stock of everything we've done so far over the escalation journey of the last couple of years, noting that there's been some changes in status and we're introducing some new themes into the mix, and producing a programme of work linked very closely to the transformation programme of work we've already got in flight within CTM, to come up with what we believe is going to be the closeout plan for CTM, the path to de-escalation. So just to recap where we are then, we've met with Welsh Government, we've got the quarterly meetings that are now set up and in the diary for us. And we're linking this very, very closely to existing work streams as well. Just to pick up that we still got independent member champions as well that are aligned to each work stream or each area of escalation. And something that we need to pick up is then obviously looking at an IM champion for new areas that we're introducing into targeted intervention.
Thanks, Matt. That's really helpful. So that's everything from me, Emrys. And just in case there's any questions, I pause there.
Okay, thank you, Paul. I invite members to raise any questions, please. Linda.
So thank you. I'm thinking that the board would find it useful just to hear about the new industrial action notifications that have come in this week, because I think it's worth noting that what we're seeing is quite something of an escalation. So we're, as Paul said, we're running a gold command structure to plan, our approach to these, but we're also planning for the impact of teacher strikes, where that may impact on staff's ability to come into work as well. So the first teacher strike is next Wednesday, and there's others middle of February, middle of March. But the most important day to note is Monday, the 6th of February, where we have both RCN and Ambulance Unite workers on strike, which that's a Monday and a coincidence of two sets of striking workforces. And on the 7th, we've also got RCN taking action, as well as midwives and physiotherapists. And then sorry, it's GMB on Monday the 6th. I misread that. So Monday the 6th, we've got a real sort of confluence of activities. And I would say that we have managed it well to this point. It obviously does come at the expense of planned activity, because those staff that are working need to be directed to those areas for urgent care.
Thank you for that, Linda. Can I just ask another question? We've got Ian, please. Ian, to come in, please.
Yeah, thanks, Emrys, and thanks, Paul, for the report. A couple of questions. First of all, it's really great to see de-escalating from 4 to 3. I note the quality and safety are sort of monitoring the roadmap of how that's going forward. And will we have a chance, the rest of the board members, to see how that progresses over time and how we hit in those targets in terms of that? So that would be quite interesting. And the other comment really is, as you know, Paul, I attended one of the MyStake meetings as well, and I found it really, really positive, and sort of mixing in with the community afterwards. I'm one of the community as well, so sort of mixing in with people there. I knew quite a lot of them. Very, very positive feedback, and I think really, as you said earlier, I think it's really a model of how we do community engagement. And lots and lots of good ideas were coming out of that particular meeting, which we can have a look to take forward now. One thing I think I think maybe they'll be waiting now. The committee will be waiting for what we say as a response. And I know we talked about something like a "you said, we did" type of thing, and answering all the points that were raised. So that'll be something that'll be. I think everyone will be waiting for, and I myself, as a member of the community, will be waiting to see that as well. So thanks for the meeting. I think very, very positive.
Thanks, Ian. And yes, Dale, who's leading the programme work, has already got a plan now of how we're going to get something out quite quickly to bring together a summary of the feedback that we had from the sessions, and also to explain to people what we're going to do next under the various items that were raised. So that's going to be coming out shortly. Just on the point around Teeth Lydiard, there are regular updates already to the Quality and Safety Committee around Teeth Lydiard, but I think, Emrys, perhaps it might be something down in perhaps the next boarding or sometime in the next few months, where we might want to get the team along, because I think there's a really positive story to tell about what's gone on at Teeth Lydiard, and I'm sure Lauren and others would welcome the opportunity to perhaps come and give an overview of the journey that they've been on, and how the service has really sort of moved on significantly over the past year or so.
I concur with that, Paul. I think that's a really good suggestion. That was a good proposal, and I think if Lauren comes with a team, we can sort which meeting is to come and do that presentation to certainly and the other thing as well is the learning that we can share in other parts of work that we're doing across the organisation is a good idea. Can I also just come back to Linda's point, Paul, as well? Is that obviously Linda's identified the issues that or the industrial action coming up. I suppose the other message we just need to confirm here is we know what perhaps the implications are, but also that we've got plans in place to respond to the changes that we might be experiencing or could be experiencing on those dates.
Yes, so as Linda explained, the goal command structure that we have means that we have executive level oversight of the preparations for the strike days. And then obviously there's a silver and bronze command structure that sits underneath that in terms of the operational day-to-day management. As you all know, there's been derogations agreed with with various unions for around certain key services that need to be maintained during that period of time. But it does result in us having to juggle services around. We have to cancel some things on strike days just because we don't have enough capacity to be able to continue to provide all the services. I think it's also quite interesting, particularly with the ambulance strikes, that because obviously people are being encouraged only to contact the ambulance when they absolutely need an ambulance, we do see quite low levels of demand on those days in terms of ambulances coming into the hospital. So it does mean that we're seeing lower levels of activity, which is obviously helpful when you're in a pressurised situation. I think it will be interesting, as Linda's highlighted, on the Monday the 6th and Tuesday the 7th dates, because those are the first days where we've actually had sort of several unions all on strike on the same day. So I think we'll just have to make sure that we closely and monitor that, but we've got the processes in place, Emrys, to oversee those challenges and react appropriately should any particular pressures come to light on the day.
Thank you very much, Paul. Wendy, can you confirm if there are any remaining questions or any objections raised, please?
Nothing further, Chair.
Okay, thanks to Paul for presenting the report. In concluding the item, the board resolves to note the report. On to item 5.2, which is the Board Assurance Framework. I invite Callie Hamblin to present the Board Assurance Framework Update Report, which was received by the Executive Leadership Group on the 16th of January 2023 and is before the board for approval. Callie.
Thank you, Chair. The report before members hopefully is quite self-explanatory, so I just want to draw members' attention to section 3.3 of the cover paper, just to highlight that one of our strategic risks, risk 7, leadership and management, has been reduced in score during the last period in terms of coming down from a 16 to a 12, and hopefully the rationale on that is clear within the paper. In Appendix 1, which is the Board Assurance Report, any changes and updates are identified in red, and that is following a robust review with my team and each of the executive and their leadership teams over the last month or so. So there's nothing else I really wanted to pull out of the report, but of course if there's any questions on the specific strategic risk, Chair, then I can bring in our executive colleagues to answer those. So really that's all I needed to highlight.
Thank you, Callie. I invite board members to raise any questions, please. Patsy.
Thanks, Callie. Thanks, Chair. Yeah, I've got questions on 2 sections of the BAP, and again, it's improving all the time. So congratulations on that, and thank you, because it's quite an easy read now. Excuse me. Risk number 9 talks about the environment and the social duties, ambitions, but it doesn't talk much, and it doesn't say much in the detail about the public health need. It identifies the Assurance Committee as Population Health and Partnership, which is exactly what you'd expect, but it just doesn't really get to grips with the public health need. And we know that poor health within the population is a driver of a lot of our health needs, so stroke, obesity, things like that, has massive consequence. Yet the mitigations and the risk
doesn't go into any detail of that. So that's one point. And my second point is on section 3, improving health. Under governance and innovation, it says the innovation board has been stood down, but each site now has its own operational management group. And I wonder how this works, given we've moved to a cross-site care group model as opposed to an individual site group. It seems a bit like round peg square hole type situation there. So they're my 2 points. Thanks.
Thank you for that, Patsy. Callie, is this where you want Linda to come in?
Yes, please, on the first point Patsy raised.
Okay, Linda, if I could invite you in, please.
So what I'm going to suggest, Chair, is that Sarah Thomas and I review this to make sure that we're clear about the purpose of this particular goal and risk area, and that we respond to Patsy in an appropriate manner. We'll do that before the next meeting. What I don't want to do is repeat things that are elsewhere in the bath, and it may be that we just need to edit it to make it clear, because it's a fair challenge. So we'll have a good look at that.
Thank you for that, Linda and Sarah. And just to check if that's okay with you as well, Patsy, to move it in that way. Thank you. And is there another point we wanted to respond to as well there?
Yes, Chair, if I may, it was on the innovation board, Patsy, wasn't it? Was it strategic risk-free you were referring to?
Yeah, under section 3, strategic risk 3, yes, you're right, improving care. It just seemed a bit counterproductive to move from, given that we've moved to care groups, to remove something that was whole site, effectively whole organisation, back to a site thing. That's more an ILG response than a care group response. Didn't understand the rationale there.
Okay, perhaps I could bring in one of our executive colleagues for that, or we could take it away and just look into that offline with our innovation team, Patsy, if that's okay, and feed back to you outside the meeting.
Yeah.
Okay, just to check on that then, is that you don't want an exec to come in now, Callie, it's something to do outside the meeting, is it?
I think, yes, I think the innovation team, if we could link in with them, unless Greg's got a point he'd like to pick up on that.
Yeah, I'm happy.
If I can invite you in then, Greg, please.
Thank you, Chair. Probably need to look a bit more at the detail, Patsy, but we used to have a centralised improvement and innovation board. And as we were progressing through delivering the ICTM business plan, we now have faculty improvement and innovation leads out what was within the old ILGs, but now within the care groups. So the vision was always not to have just a centralised team focusing on improvement and innovation without input from what is now the care group teams. Hence the reason why we've reached out to include a wider faculty. So innovation and improvement isn't something that's out with the governance of the new care group model. Clearly, we still have innovation and improvement CTM that are supporting, from a central perspective, innovative ideas out within the care group. So we haven't lost anything. We were just mindful that as we progressed through the new operating model, we wanted to integrate improvement and innovation more within the care groups than as a standalone project in itself. I think with the new National Safe Care Collaborative, which we've signed up to as a board, we're just about to kick off some of the work in that regard. There will again be central oversight of the improvement and innovation work within the care groups going forward. And again, happy to pick up a bit more detail in the conversation with you, Patsy, in that regard.
Thank you for that, Greg. And just to confirm then, just to further develop any further discussion on those points, we can take them outside the meeting. Okay, if I could invite Jane in then, please.
Thank you, Chair, and thank you, Callie, for presenting the report.
I've just got one point to make around strategic risk 1. And on page 4 of 35, we have the specific improvement groups and boards clearly identified now in this new version, which I do like. And on the following page, we have under the governance structures, the Prince Charles Hospital Improvement Board having been stood down. I just think that what we need to build into our processes is a final learning piece when we actually stand down these boards, identifying clearly what learning we have and how we are sharing it across the health board. I'm actually simply repeating what I said at Quality and Safety on Tuesday, but I think it's important for all the board to hear, and I think it also builds on the point that Ian raised earlier around Tichlediad. So that's the comment I wanted to make, Chair.
Okay, thank you. Jane, do you want to respond from yourself there on that one, Callie?
Yeah, thank you, Jane. I think we picked up on that, as you said, in Quality and Safety Committee, and I think it's a key thing that we're trying to bring through the listening and learning framework that we've implemented. So I think, yes, that's something that is being taken on board and definitely taken up through the new care group model.
Thank you.
Okay, thank you. Wendy, can you please confirm if there are any remaining questions or any objections raised, please?
Nothing further, Chair.
Okay. Thanks to Callie for the report. In concluding this item, the board resolves to approve the board assurance framework. I now propose to take a break for 5 minutes, and we'll come back at approximately, well, just over 5. We'll come back at 11:05. And I just advise you all to switch off your cameras and microphones during the break, please. Thank you. Okay, can I confirm that we're all back in the meeting, please, Wendy?
Yes, Chair, we can recommence.
Okay, welcome back to the meeting. I want to go into item 5.3 now, which is the Integrated Performance Dashboard. There are a number of execs who have a lead on integrated performance. So we've got Linda Prosser, who's the Director of Strategy and Transformation, Gethin Hughes, the Chief Operating Officer, Greg Dix, Director of Nursing, Dom Herford, the Medical Director, and Howell Daniel, the Director for People. Before I invite executive colleagues to present this item, I just want to advise members that I will firstly ask Linda Prosser to lead this item. I will then invite in the other executive leads to present the operational quality and people and culture sections. May I ask that members hold their questions until the report has been presented in its entirety by the aforementioned executive leads. To support members in navigating the page numbering for each section has been noted on the agenda in admin control for ease of reference. I now invite Linda Prosser to provide an introductory overview. Thank you.
Thank you, Chair. As board members know, we are continuing to work towards a conversation about how we develop this report further into one that has more of a hierarchy of measures and areas for us to look at as priority areas, because I know that there's a lot in here and it can be quite difficult to kind of understand where to focus. But whilst we're still working on creating something new, which will take a bit of time, we continue to seek to improve this version. So there's a couple of things that I wanted to just address from last time where there were questions, and the first one is on page 5 of 42 or 215 of 309. So a very legitimate question asked last time about why there's only one, it's at almost the penultimate measure on that page. There's only one data point, and we have checked that. There wasn't a prior data point to 1920 because that was the year that we were first a single organisation, and there has not yet been a report on 2021. And I think that's clearly due to COVID. So I'll talk to Sarah Thomas outside of the meeting to get more of an understanding of when we might get that. There's also in the quality section, you might note that we have now put the nationally and locally reported incidents on the same scale of axis. I think we've also had some conversations since the last meeting where relevant about the choice of use of SPC methodology. So that might be a question that comes back in, but I know that we've followed through on the intentions there. And apart from that, I think we just continue to work in the narrative sections and the presentations just to try and make the descriptions clearer. So I'm happy to take comments on that, either at the end or in outside of the meeting, but hopefully that you can see that we are making this an easier, slightly more digestible while we wait for a more what's the word I'm looking for, a sort of hierarchy of reports, so it's easier to work through. So I think what I'll do now, Chair, is hand back to you for the first executive to bring their report through.
Thank you, Linda. I'll invite Gethin Hughes to present on the operational performance section of the report, please.
Thank you, Chair, and good morning, everybody. I was going to present this in three sections. The first addressing urgent care and stroke, the second picking up planned care and cancer, and the third area then focused on mental health performance. And what I'll try and incorporate within the update is also what had previously come to board as separate updates on the planned care recovery programme and also on the 6 goals programme. So in terms of urgent care, as Paul addressed in his CEO's report, December was an exceptionally challenging month. and huge thanks to all of our clinical staff and support staff who really did step up massively to respond to the demands. As you'll see, we saw A&E attendance is 18% higher than the previous December, and I'll be honest, it felt like that. So the teams have worked exceptionally hard, and I think what the numbers also don't set out is the acuity of patients. And during December, we had a real spike in very poorly patients with flu and also other respiratory illnesses. We had to open up surge capacity, unfunded surge capacity in our intensive care units to accommodate those patients, and teams across all the sites and within the community really did go the extra mile to make sure that we could accommodate every single patient. I'm afraid to say that you know, the privacy and dignity and the experience for patients during that time was sadly compromised, but we really did want to ensure that we were able to accommodate all the patients that presented to our hospitals during that time. Clearly, that has a material impact then on urgent care performance. And you will note that performance across all metrics in December was particularly poor for urgent care. What I do want to do, though, is just, if I can, if we were to revert back to page 31 of the report, which sets out the levels of delays that we have on our acute and community sites. And what you'll see is that the delays that we experience of patients moving on to either their own home with a package of care or onto a nursing home placement is significantly higher than that experienced elsewhere in Wales. And that has a material impact on our ability to respond to the front door pressures. Because we don't have the capacity, the bed capacity within the hospital, we end up holding patients for a prolonged period of time in the emergency departments. That then has an impact on our ability to offload ambulances, and therefore also has an impact in terms of our ability to have timeliness of response to patients in the community. We have taken a number of actions and are working exceptionally closely with our local authority colleagues. We've gone live with the new electronic whiteboards, so we have one electronic system now for recording the status of every patient in every hospital, and can do electronic referral then to local authorities of all those patients. So it's really you know, a significant step forward for us as a health board to understand the status of every single patient live every day in our hospitals, and can really support us to move those patients through. As part of that programme, we've introduced a discharge to recover and assess model. And that equally has gone live. We've opened up beds at Brocastle Nursing Home for that pathway. And we've also opened up an additional ward at the Princess of Wales site with a very different staffing model that allows us to manage people on that pathway. So all of those things are really important aspects of how we can manage the capacity and demand within our hospitals better. There is a significant piece of work we need to undertake to really release that latent capacity so that we can provide really timely emergency care. We have changed some of the processes within the A&E departments themselves. You will note the challenge we had in December on red releases being declined. We have changed the process on all sites, but particularly at the Princess of Wales in Bridgend. I'm pleased to say up until today, we have not declined a single red release. So that process is working. We've had good engagement from the clinical team, and we hope to sustain that performance now going forward. It's really important that we are able to release ambulance services to those who are most vulnerable in our within our community. We also, as part of, mobilised more quickly over the Christmas period to support the pressures, the navigation hub. Now, this is an initiative that's been set up by and led by Owen Weeks, who's one of the medical directors for Unscheduled Care. And this is a GP-led hub where a variety of health and social care professionals can access urgent GP advice on how best to manage patients. We accept calls direct from care homes. We accept calls from the police. We accept calls from WAST, from our own community professionals, and also if the emergency departments think there are alternative pathways, they can refer the patient back to the navigation hub. That was set up at pace over the Christmas period, and has had a huge impact, and has, where you can see the data is very clear, and we'll take an update to PPF for further scrutiny. That where there is contact to that service, the rate of conveyance to hospital is negligible. So it has a really important role to reduce conveyance rates to our hospitals. We know the patients who end up waiting longest on ambulances, and we had this discussion at Quality and Safety earlier this week. Those patients that wait longest on our ambulances are the least acute patients, but they're often some of the most frail. And these are patients whose needs could be met in a different way, either in their own home or in their nursing homes. And so part of the navigation hub is to make sure that we can manage those patients in a better way, a more appropriate way, and certainly a way where their dignity and is more safely managed. Clearly, as part of that, the emergency pressures has a material impact on our ability to deliver against some of the stroke standards. So we know, clearly what we want to ensure is that all suspected strokes come to us via an ambulance, so that we've got early notification and can move that patient through as a pre-alert. That is a key development that we want to ensure happens within our services. The other key aspect is protecting stroke access beds, so that we can get patients into our acute stroke units in a very timely way. Interestingly, in the last week, we have managed to keep ring-fence stroke access beds on both sites open. So it is possible, and as we see a reduction in the number of patients waiting social care-led discharge, we can further protect that. But that becomes the first important element of improving our stroke performance, and will support access to thrombolysis and thrombectomy if clinically appropriate. So an awful lot of work continues on urgent care. We've got a really strong leadership team now within that care group, leading that this programme with good clinical engagement. And of course, members will be aware that the HIW report into the Princess of Wales Emergency Department from earlier last year was released yesterday, which certainly highlights the lengths that our staff go to keep patients safe, recognising the pressures that the department's under, and the very significant impact that flow out of the hospital has on that department. I will will then move to, if I may, is planned care, Chair. So you will note on page 20 of the overarching report that the two key metrics for planned care recovery, 104 days and 104 weeks, sorry, and 52 weeks, both of those metrics are green. Now that is green against our own internal plans that we set as part of the IMTP. It is not green in terms of the ministerial ambition, as part of eradicating all waits for 104 weeks for treatment and 52 weeks for a first outpatient appointment. That target now has moved to end of June this year, and will be and we're currently revising our plans. I think it is important to sort of highlight to board the size of that challenge. You know, as we look at that, we've got you know, the core specialties, or where we currently have the biggest risk in there for stage 4 treatment. As it currently stands, we have 1,600 patients waiting who will be waiting over 2 years of treatment in orthopedics by the end of June, 1,000 patients waiting a gynecological operation, 700 in general surgery, and around 650 in ENT. Now, that is based on patients who don't have a date as of today. We know that many of our theatre lists will be booked. And I am pleased to say that we went live with the reconfigured orthopaedic model a week early. So we were able to get the orthopaedic inpatient ward back online a week earlier than planned, and that model is going exceptionally well. The use of the insourcing theatre teams has gone down, or working exceptionally productively with our own teams, and we are seeing improved efficiency across our theatre template. What's also great is whilst phase 1 of orthopaedics was focused on the Royal Glamorgan Prince Charles, Kesh Singhal, one of our orthopaedic surgeons from Princess Wales, has moved a list up to Prince Charles Day Surgery as part of that reconfiguration. And we are looking at both medium-term plans, i.e. later in this year, how we can release a second orthopaedic theatre at Royal Glamorgan, but in the interim, are there reconfigurations of some operations that can release certainly some more theatre lists on the back of that. So very clear for each of those specialties, having clear plans to reduce that backlog to the lowest level we possibly can by the end of June. And in a number of those specialties, that is eminently deliverable. I guess the key risks to flag in terms of operating is ENT, because of the availability of nationally of ENT surgeons, but also in urology, where we have a significant challenge on our urgent pathway, which then means that we don't have the capacity to manage our routine backlog. And then there are a couple of other smaller specialties where we're looking at those key pieces. We then, in terms of 52 weeks, are again currently, if you were to look at what is undated today of the at-risk cohort, we've got 30,000 patients waiting who currently will breach 52 weeks unless they have an appointment date in that time. The key top contributing specialties there is ophthalmology, which is 7,500 patients, ENT, which is 5,000 patients, dermatology, which is sitting just below 4,000, and urology, which is sitting at about 2,500 patients. So a number of those specialties appear as challenges for both stage 1 and stage 4 treatments. So there's a level of work going on to understand how we what are the different options. So there are cohorts of patients that perhaps can be managed in a different way. There are patients that are being referred for or on treatment lists for procedures that probably are not appropriate to be undertaken. And and how can we temporarily increase capacity in those where we know that their demand capacity position is in equilibrium, but it is about backlog clearance. We have secured support from Welsh Government for some additional funds between now and the end of March, which have to be spent clearly by the end of March, and we're working with some outsourcing companies to try and maximise the transfer of patients who've been waiting the longest out so that they can get their care progressed. In terms of cancer, as you'll see, we remain with two very challenged specialties in terms of cancer, which contribute to the vast majority of our challenge. The first is lower GI or colorectal, and that is driven primarily due to timeliness of access to endoscopy. Committee members will be aware that we have 6 endoscopy rooms. We have a 7th room, which is a temporary facility. The modelling for us suggests that we probably need a further 6 rooms as a health board in order to be able to deliver a maximum 2-week wait for endoscopy. So we have a significant demand and capacity gap. There clearly are longer term plans about how that can be addressed, but in the short term that continues to whilst we look at every way in which we can drive the efficiency through our endoscopy pathways for our cancer patients. There is a challenge which we're working with Bowel Screening Wales on, because a large number of those patients come through the bowel screening process and are either at or over breach date when they arrive with us. So we are looking at how we can improve the pathways there. The second specialty where there remains a challenge is urology. As I touched on, so we have a number of challenges around urology in terms of demand being higher than plan. We have some significant fragility within the workforce with a couple of retirees and a consultant seeking to reduce their hours. And in terms of the complexity of the diagnostic pathway in urology. So we're working with the delivery unit on both of those topics and have their support in terms of really understanding the modelling, where other health boards have delivered different ways of running those pathways. But they remain significant risks and will continue until we're able to provide the requisite capacity. We'll continue to challenge our ability to deliver. The teams are working towards a sub 200 patient count for over 104 days in cancer, which will be the lowest that we've had for a significant period of time, but it is nowhere near where we need to get it. And so there is an awful lot of focus and drive on cancer. We are treating more cancers every month than we were previously, but the timeliness at the moment is compromised. The final piece then is around picking up on mental health, and there are sort of 3 key areas I just wanted to pick up. The first area of concern is around psychology. And access to psychology. We have got 2 big programs of work going on there to address those challenges. The first is led through the mental health recovery program. So we are just finalising contract award to an outsourcing firm who will take a proportion of our backlog and will deliver the backlog for us. And a second and they're reworking the demand and capacity model sitting within that service as part of that. The second development that we've introduced there is also around using psychology assistance and managing patients who perhaps require less intense programs or programs where they can have a much shorter period of time within the intensity that a qualified psychologist will give. I think, you know, coming back to the conversation we had as part of the WISE program, this is where we've got opportunities to think about patients moving between those different scores. We are seeing a good backlog reduction in the 1A, 1B of CAMS, despite the demand rise. We won't see performance improve until we've cleared the backlog, but the backlog is going down. The area where we've got greatest concern, and again, we touched on this as part of the Quality and Safety Committee conversation, is around part 2 of CAMS, and there is a revalidation process underway looking at the caseload and making sure that those patients are all being appropriately managed as part of that, and we can give a further update to board on that at the next meeting. The other piece I just wanted to raise, so board will be aware that a couple of months ago we had concerns about CHRT gatekeeping and some very low levels of performance. Following a review and a change to the pathway, I'm pleased to say that we've seen that performance now hit well up into the 80s, and we know that performance will continue to improve. So there's been some very focused effort there from the mental health team on addressing those challenges. I'm happy to finish there, Chair, in terms of the overview of the performance, the operation performance report.
Thank you very much, Gethin. If I could now invite Greg Dix and Don Purper to present on the quality section of the report, please.
Thanks very much, Chair. I'm just going to pick up page 12 in relation to complaints and concerns. So we had a good run through the quality report at Quality and Safety this week, just last Tuesday, but I'm keen for board members to spend a little time with me talking through complaints. So you would have noticed that we have a very poor 30-day compliance rate for complaint responses, and it's been on a downward trajectory really since September, October of this year. We're just coming to the end of a organisational change process in regard to my central quality governance team, which will address some of the capacity gaps we currently have within the central team and out within the care group teams. And as Gethin's just articulated previously, it's been exceptionally busy over the last couple of months, and some of our senior nurse leaders and medical nurse leaders have gone back to supporting clinical care delivery on the front line and leaving little capacity for some quality governance activities, although things are starting to settle down. You would have noted probably on the run chart as well on page 12 on the left hand side, over the last year we've seen a reduction in formal complaints, which is great, and that's generally related to the new triage system we put in place, but also a lot of focused work on early resolution. So anybody that submits a complaint to the organisation, we do what we can to resolve it as quickly as possible, which you can see has had an impact. So therefore the formal complaints that now come in are much more complex, providing a lot more work in relation to the investigation that needs to take place. I still think we have some work to do from a quality perspective in relation to the responses going out. Certainly with the new changes to the central complaints team, there'll be much better consistency and standardization of complaint responses. But in the interim period, we have introduced a further quality assurance check within my central team prior to final sign-off. So when the final letters do go out, the letters absolutely address the initial concerns that were raised. We've also introduced a balancing measure, which I can include in future reports, and that's in relation to reopened complaints, which is a marker of whether people that raise a concern is satisfied with the responses that we provide. So there is some further detail in relation to the improvement programme we now have in place for the central concerns team going forward. The methods of learning continue to align to our listening and learning framework. So whether it's 7-minute briefings or care group governance teams meetings, or whether it's something we put in our leadership forum. So there are many methods in relation to learning and sharing, but definitely not where we need to be. But I would like to provide some reassurance and assurance to the board that we acknowledge where the challenges lie, and I'm confident now with our improvement trajectory going forward that we'll get back on track over the next few months. That was it from my perspective, Chair. I'll hand over to Dom now, who will talk through some of the wider safety issues.
Thank you, Greg. I can invite Dom in, please.
Thanks, Greg. So I'm going on page 13 of the 42-page document here. So first thing I'm cover off is the medication incidence and the mortality rates. So medication instances, we can see there is this a mean. We seem to be floating around the mean. The positive thing about this, apart from once in the last year, we've stayed below that mean that we have had in the past. So definite improvement overall for you to plot that slightly differently. Obviously, as we still say every time, you know, even one mistake is one too many. But we are the learning is in there. We are getting it out to the teams. I think there is an element of concern that there were going to be an increase in with the acuity of patients coming in and the number of cases that we're getting in coming through our ED, that actually prescription errors would increase, but that's not shown to be the case. So we're shown to be safe despite the fact of the increase in the pressures that everyone's under. So I think that that's a positive to take from it, but still more work to be done there. The mortality rates is a slightly different story here. So these aren't comfortable reading, let's be honest from here. You can read from here that CTM does appear to have a higher crude mortality rate as provider of services compared with the other health boards in Wales. The overall numbers are declining. If we look at the first graph, you can see obviously the two huge peaks that we can account for, obviously with COVID, and since then we've been sort of moving around about the mean of that. Traditionally, what we've always said on these, and one of the many reasons that we've explained, is that we include our palliative care and hospice data in here. Now, not all health boards do, but some actually, it appears, are including them as well. And despite that, we're still higher than that. And we're not happy with this data in any way. I don't think anyone should be. So we've set up a group, specific task and finish group, to look into how is it that our data is as it is. Is our data actually accurate? Where is the actual spike as it occurs? The way that the data is out there at the moment, it's very hard to actually tap down to work out exactly which area and what it is. So we don't know where to focus that energy to start addressing some of those concerns. A lot of this is coming up through the level 2 and the level 3 mortality reviews that are happening, and there are general trends in there which are in keeping with the other health boards. When we share those ideas with them as to where our concerns are, they do chime with the others. So there is work to be done here, and this task and finish group, I will be having report into the Quality and Safety Committee to give progress really as to how we're doing with that. I will pick that up with the Deputy Chair outside of this meeting to fill her in on what that project entails. The other thing I then wanted to raise and talk about here was the Sepsis 6 bundle on the next page. Now, the data on here, it's quite a mindful of those of us who are slightly colour challenged. I appreciate on that. The data here doesn't look that good. But there are some reasons behind it. Our inpatient compliance with the septic cyst actually fell from around 55% to 80% in September last year. Now, the reason for that is not that we suddenly stopped treating people or stopped addressing the septic cyst. We actually rolled out a new form and a new approach to energise people into focusing on it. And if that form wasn't completely filled in, then it was rejected as not being met. The compliance wasn't met. So part of that is the reason that we've created this for ourselves by tightening up and setting our own benchmarks higher for proving that we have met it. Now, that might seem counterintuitive, but actually, if we want to improve things, we've got to make sure that that standard is there that people follow. So that's one of the reasons for this. Also, because we've rolled it out to all of the wards, and this isn't just a focus on the ED teams, we're actually finding that we're looking for more cases, we're filling in more forms, and therefore we're finding more cases of sepsis 6, sort of non-sepsis 6 compliance. Now, that may well be that this is actually a true picture of actually what is going on, and up to now we've skewed our data slightly. So this is an opportunity for the team, the acute deterioration team who are leading on this, are really looking at the data and working through and pushing that compliance and completing the forms in the right way. So it's an early process. The other factor which we do have to take into account here is the pressures on the ED have meant that might be a cause as to why our compliance has dropped as well. And also the fact that our outreach teams, because of the higher acuity of patients, they've been called to more patients, they're seeing more patients on the wards in ED, and they're also, when intensive care is over capacity, have been pulled onto the ICU units to help there. So there's another reason why maybe our outreach teams aren't able to pick this up so well. I'll stop there because I know there's going to be a question from Nicola on this, and I know that Nicola's actually spoken directly to the acute deterioration team on this fact, so I'll stop to allow Nicola to come in.
Nicola, is it okay to invite you at the end of the total presentation, and then I've got you down as first in, then on the questions then, if that's okay? Can I now invite Howell Daniel to present on the workforce section of the report, please?
Thank you, Chair. Good morning, everybody. So just wanted to highlight to colleagues some of the main workforce metrics within the performance report, and just for ease, I'm looking at page 17 of the report. So just starting on PDR and core skills. So as you'll have heard me say over recent months, we're not where we'd like to be on either PDR or core skills at the moment. Albeit we are starting to make very slow progress on both of them. So we've got an uptick in PDR performance over the last couple of months, a subtle uptick and not quite at the pace we wanted to be, but an uptick all the same. And in doing that, we had also arrested a decline in PDR rates, which had been ongoing since early 2019. So that is a positive, and hopefully we will continue to see an uptick and that tick up at a faster pace using the new PDR process that we've introduced, and as the care groups settle down and begin to monitor some of this performance locally. Similarly with core skills, we saw a dip in core skills from 2019 going into 2020 and 2021, perhaps for understandable reasons. Then we saw an uptick and a bit of a decline towards the end of that, and we're now seeing core skills levels creeping back up again, almost over 70% now. Not quite where we'd like them to be, but again, good progress. We have got some particular risk areas which you'll see, but plans in place to work on those. And again, as the care groups settle down, we would hope to see performance pick up. Also just wanted to mention on page 18, sickness. So we've had a tricky position over a couple of years now in relation to sickness absence. You'll see the significant peak that we had in the second wave. Really, it took most effect of COVID, up to above 9%, and traditionally our sickness rates in this organisation hover between 5.5% and 6%. So that gives you an idea of how significant that peak was. We then dropped significantly down to 5%, which we hadn't been at for quite a while. And then over the course of 21-22, we saw an increase again with COVID peaks up to around about the 7-8% mark. What is happening at the moment is we are on the trend line, at least, seeing a reduction in sickness absence, but it has not normalised to pre-COVID levels. And there are two reasons for that. I think a increase in prevalence of anxiety, stress and depression, which of course is something that we are very concerned about, and we are focusing our well-being offer on. And I'll also talk a little bit more about this later on in item 5.7 on turnover and retention, but also an increased prevalence of cold, flu, and difficult winter periods we're seeing reflected in our population and in demand at our hospitals. We are also seeing reflected in our workforce. So December, for example, was an extremely difficult month for us, not just in terms of what we dealt with at our front doors, but also the availability of our workforce. We had huge numbers of sickness absence related to cold, flu or other types of infections. That's probably all I wanted to mention for now, Emrys. As I said, there is a specific turnover report on the agenda, so I'll pick up some of the broader issues in relation to turnover, workforce planning and retention there, if that's all right with you, Chair.
Thank you, Howell. Okay, if I could invite independent members to ask any questions should they wish. And the first one I've got is Nicola, please.
Yeah, thank you, Chair. My question is around the sepsis, the graph, please. And I'm hoping Dom can help me. The information is based on probable sepsis, the data, and for probable sepsis, there should be the bundle within 1 hour. And I'm a bit confused on the data, Dom, because it says, for example, here, if we look at the last one for the Royal Glamorgan, so we've got just under 60% that receive all 6 within an hour, but yet the compliance line is up at 70.8%. So I'm a bit confused. Are we only doing below 60%, for example, for RGH, or are we 70.8% compliant?
Yeah, it's not very clear, is it, on that whole thing? It's 60% of possibles or probables have been included in this data here, but those that are definites, our compliance is up to that 80%. Does that make sense? So if we look at all the probables that we've got there, we're only capturing 60% of those, but of those that definitely have got sepsis, actually we've been compliant in 80% of those, achieving it within the hour. So those that have proved later on confirmed they definitely are cases, we've done well in getting 80% of them done, we're still 20% short, but what we're not managing to do is make sure that all the probables are done within that hour. I think I probably need to split that data into 2 rather than trying to be clever and put it on one graph and reduce the amount we've got in there.
I think that might be helpful, Dom. Thank you.
No problem at all. I'll pick that up for next time. Thanks, Nicola.
Okay, thank you, Nicola. Thank you, Dom. If I could then invite Patsy in, please.
Thanks, all. And I'll start by acknowledging what Linda said right at the beginning of the presentation, that this is a report under review and it's recognised there are improvements to be made. And on that point, I would like to say thank you for improving the locally and nationally reportable incidents, in that the axis is now the same, which allows a good comparison and correlation, if that's appropriate, of those 2 graphs, so that makes it much easier reading, and also to recognise from the action log that I'm meeting a member of the team to discuss the SPC charts and the change in upper and lower control limits, so that's all in hand as well. I've only got 2 questions on this whole report, and one of them comes back to the locally reportable events and the table, and the second line on the table is admission, transfer and discharge. There was 1 in January 22, then nothing till October 22, and November there were 8 and December there was 1. I don't know if this data truly represents what's going on, because it seems strange that under that heading of reportable incidents, that December, when there was so much pressure in the departments, that there would only be 1, yet the month before there was 8. So I don't know if there's a reason for that, if something's changed, but there was that whole period where there was nothing, and then a little cluster has appeared. So that's one. And my only other question is on the falls, and it's more of a comment, because we had a long discussion in Quality and Safety Committee around the falls data not very long ago, and it's a comment really. The paper recognises the information is not accurate, and therefore I would question why include it in a public bundle, because if it's not accurate, it's misleading, and if it's misleading, then that leads to unnecessary time wasting. So that's more of a comment than a question. Thanks.
Shall I? Patsy. Greg, are you going to respond to Patsy's comments? A question? Well, there's question and comment. Anyway.
Yeah, I think so Patsy's absolutely right. So I think we need to rethink how we publish the falls data, because acknowledge it can be and is misleading. It is a frustration of us and other health boards in relation to the DATEX, the new DATEX system, and how it's tricky to downgrade an initial categorization of harm, and that's something that the national team's working on. So I'll take that away, Patsy. In terms of the LRIs, I don't know the detail of November, but maybe what I can do going forward, if there's a spike or a special cause variation, we could add some more detail to this report, so we understand what the spike is. I do know, though, under admission, transfer and discharges, there are about 20 subcategories that sit underneath that. So maybe what we need to do, not maybe, what we absolutely need to do is when we see a spike, we'll need to provide some more narrative in that regard. I can find that out for November and get back to you with the detail, Patsy.
Thanks. Yeah, thanks, Greg.
Thank you, Patsy. Thank you, Greg. If I can invite Jamie then, please.
Thank you, Chair. A couple of comments, really. Want to thank Linda for the progress that's being made on addressing issues regarding the presentation of data in this report. There are a couple more things that I will contribute to offline to helping with that. We are seeing progress. We had the meeting of the Quality and Safety Committee on Tuesday of this week. I thank Gethin for the comprehensive report that he's given here today. We had the benefit of that at Quality and Safety too, which clearly will reduce the number of questions in board today. I want to thank him particularly for highlighting the issues around CAMS. We had an in-depth report on CAMS at Quality and Safety this week. It's a complicated situation. There is an action plan in place and being refined. It is something that we will be keeping a very close eye on at Quality and Safety as we move forward, and I just wanted to give the board that assurance of our attention. Thank you.
Thank you, Jane. Are there any further comments or questions? Just checking on my... Can I just ask one question, Dom? In relation to the crude hospital mortality rates, and obviously we've had a presentation today about we've got people waiting for discharge from the hospital as well, so it's about appropriate use of our assessment treatment beds. And not to go into any detail for today's board meeting, but what would be helpful, I think, for me is to understand outside the meeting is that when you're doing your investigation, as you referred to earlier around crude mortality rates with our service, it'd be interesting to learn about if there's any correlation between, you know, what the beds are being used to, length of stay, etc. You know, as to whether they're assessment treatment beds or the assessment treatment bed's been taken up for something else as we're waiting for someone to move on out of the hospital. I'm not expecting a big response to that, Dom. It's just that it would be useful to have some conversation about outside the meeting as well.
Yeah, no, absolutely. I'd be very keen to take that on. The team have started looking at some of those factors, but we can work that into every case. Yeah, I'll pick it up outside the meeting up, Emrys. That'd be great.
Yeah, that's good. Thank you, Dom. Okay, can I just confirm with Wendy, are there any remaining questions or any objections raised, please?
Nothing further, Chair.
Okay. Thanks to executive colleagues for the report. In concluding the item, the board resolves to note the report. If I could go then on to 5.4, please, which is the Integrated Performance Dashboard Part 2, which is about financial performance. And I invite Sally May to present the report, which is before the board for noting. Sally.
Hi, as you say, we've looked at the detail of month 8, and this is the month 9 report now via committees. We are maintaining our core plan forecast deficit at 26.5 million, but it's worth me highlighting that year to date our performance is 1.4 million worse than plan. That reflects some of the pressures we've already talked about in other sections of the board and their impact on finances, but we are as confident as we can be at this stage that we'll deliver the 26.5 million deficit, which while difficult is the plan that we set out at the start of the year. We're forecasting that our exceptional costs will reduce marginally from a forecast of 17.8 at month 8 to 17 million now. That is largely due to, or entirely due to, a downward movement marginally on the forecast energy costs. What that means going into next year remains to be seen, and of course it's still subject to the energy billing relief scheme, which we know will change as of the 1st of April. We're forecasting that overall COVID costs remain at 30.1 million. Some of the key financial issues I just want to flag. I think I reported previously that we now had confirmation from Welsh Government that they would be funding our forecast costs for exceptional and COVID costs at a maximum of the month 6 forecast costs. Anything that goes over is ours to manage. Any underspends will need to be returned to Welsh Government. So as we see that forecast come down on exceptional costs, that means we will receive less funding as a result. Most importantly, though, is just to touch on what it's looking like going into next year. So as you'll remember, at month 8, we'd increased our underlying deficit to 47.6 million, largely reflecting non-recurrent savings and cost pressures. We've now increased that to 53.9 million. That excludes any of the ongoing COVID response costs and exceptional costs which we're currently incurring in 22-23 and which we're getting funding streams for this year. But these are likely to continue into next financial year. So our latest estimate of the ongoing costs for are circa 9 million for COVID response, and at the moment 27 million for energy. That represents a point in time in terms of the sort of costing of that, and more work is to be done on that, but you can see the significance of energy in terms of our look forward. We will not be funded separately in next year for those two elements, and therefore as we start to look at the challenge going into next year, it looks like a figure of around 89.9 million. Still more work to do to refine that, but I think it's important to flag the size and scale of the challenge facing us. It will continue to be reviewed and form part of the IMTP planning process. And then the other element I just want to draw attention to is cash. You'll remember from previous reports that we approved as a board writing to request cash support for our underlying deficit towards the year end. Subsequently, we've now had confirmation that 26.5 million will be cash funded, which will give us the ability to meet our commitments. We're also assuming that our movement in working balances of 12.2 million will be funded. We haven't had that explicitly confirmed, but that has been the process in earlier years, so that's our assumption. So those are really the points that I wanted to draw out at this point, and I'm happy to take any questions.
Thank you, Sally. I invite board members to raise any questions. Wendy, can you please confirm if there are any questions or any objections raised, please?
Nothing further, Chair.
Okay. Thank you, Sally, for your report to the board. The board resolves to note the report. If I could then go on to item 5.5, please, which is the Child Practice Review. I invite Dom Herford to present the report, which was discussed at the Quality and Safety Committee on the 24th of January 2023 and is before the board for noting. Dom.
Thank you very much indeed, Chair. Apologies that I'm going to pass on from Claire O'Keefe, who is our head of safeguarding for the Health Board, and unfortunately she's unable to attend today. And as I was involved in this case, I'm presenting on her behalf, and also on behalf of Greg Dix and myself, who take the safeguarding lead in the Health Board. So this is the report really that follows up the tragic death of Child T. Child T was murdered at the hands of those who should have cared for him the most, and it was a very difficult paper to read when it came out for all of us, sort of the impact it has had. There are a number of issues specifically from that we felt we needed to bring to you as the board to make you aware of what was in the report, to telling us what we need to do and also what our actions are and progress we've made to address those. The reason for this is that even though the murder of child T occurred, there's always learning that comes from it that we as a health board need to pick up on. And this is related to the fact that child T presented to the Princess of Wales Hospital in August 21, 11 months before he was murdered. In that report, he presented with what, with hindsight now, is known to be a non-accidental injury, but at the time was assessed and was discharged back to the care of his mother, with it not being flagged as a non-accidental injury. That was seen by the Safeguarding Board, who reviewed this as a missed opportunity, and we fully accepted that and have apologised to Logan's father and to all those who love him. The two main aspects from this relate to training and compliance of training, so everyone is aware of what the training requirements are, and also everyone being aware of non-accidental injury and safeguarding procedures, and also a requirement for an independent review. So we've commissioned and asked for an independent review, and this is being conducted through the CTM Safeguarding Board. And that will obviously bring up in more detail some of the aspects of this case that we need to learn from. Things that we have taken on since then, a 7-minute briefing, the awareness of the non-accidental injury pathway we have looked at and readdressed it, and that has been shared across the Princess of Wales site specifically because there are a number of teams who were involved in child T's care when he presented that we need to learn from specifically. We also had a multidisciplinary team event for all of those people who were involved and the other teams who were related to it to take what we could from this and to work out what our learning points would be. And that's developed now into an action plan together from that briefing and also from the requirements of this report. It is ongoing, it's not completed yet. It will take us a while to get to the end of that, but the process is definitely fully embedded in how we're taking this forward. Part of that is training and what the training requirements are. We've now got to the stage of working out amongst the medical teams and the nursing teams which ones need to have. There are different gradings of training that are required. Every healthcare professional has to have done level 1, everyone who works in healthcare. Level 3 is for those who work regularly with children. So in this instance, we're focusing on the paediatric team and the ED teams to make sure that they are all fully compliant with level 3 training, offering bespoke packages. We've written out to all the doctors in the last few weeks to make them aware of how they need to go and do it, how they need to go about getting that training in place, how we as a safeguarding team can provide that for them, and to make sure that everyone is compliant. And we will be monitoring that compliance, which is a requirement of this report, and we'll be taking that through the Quality and Safety Committee to make them aware to be able to question us and ensure that we're meeting those targets. So we're on track with the action plan at the moment. This isn't just about doctors, this is about the nurses, this is about the support workers, this is basically about the whole team need to be addressing and being aware and thinking of safeguarding a non-accidental injury, and it's having that awareness and also the ability to escalate if they're not happy that someone senior has said, I don't think this is a non-accidental injury, and they still think it is, how they go about ensuring that we can do that. And the fact that the responsibility sits on everyone to make a report. Anyone can put a safeguarding report in or a concerns report in, and it will be acted on. It could be anyone from the consultants, anyone who isn't even in that team who's reviewed the case from a distance. It could be any of our support staff. It could be the person who brings the dinner into the patient as well. Anyone and everyone in our department is responsible on them to make those reports in place, and we need to make sure that everyone's aware of that. So this is about how we provide our training. We've got a good package in place, how we start doing bespoke training for specific teams. It's about making sure that the independent review is listened to and we pick up on reports on there. We're regularly auditing and making sure our compliance against that training. And as I said, this is going to be a sort of a process that's going to take us a year, 2 years to really be fully on top of and have it embedded. But the most work is going to be happening in the next sort of 6 months or so. And that's really the learning points. Just wanted to bring to your attention. I'm happy to answer any questions on it at all.
Thank you, Dom. I invite board members to raise any questions, please. Are there any questions?
There are none, Chair.
One comment from Jim. I see he's just come in. Sorry, Wendy.
Yes.
Jim.
Thank you, Chair. Dom, I just think it's right. I should say I sit on the Safeguarding Executive Board and Quality and Safety, and so I've had the opportunity to scrutinise this very sad case in some depth. Can I seek assurance from you and your team that the training programme that will be rolled out would also include locums and agency staff, because really we need to try to ensure that everyone is included here. I'm impressed with the concept of the briefing notes, the short briefings, which will be readily accessible and they're easy to follow. But it's trying to ensure that things are embedded, because the underlying issues here are sort of embedded across the health service generally, and we never seem to have a lasting change of practice when we've had disasters such as this particular case. This is a disaster for so many people involved, but this is about learning from the mistakes that have been made, learning from the opportunities that were missed, and seeing how we can minimise the risk of repetitions in the future, not just within our health board, but across the NHS in Wales and beyond. Can you give us any additional comments in relation to that, please?
Yeah, certainly. Obviously, it's easier for us to manage that within our permanent staff to make sure that the training we're compliant on there. It is much harder on locum and sort of short-term work. There are some specialties, paediatrics is one of them, that actually they must have a level 3 safeguarding training as part of their revalidation process, so that we know that actually paediatric doctors has a requirement on them, which is very easy then for us when we have any locums in that area to ensure that that is in place when they come in. Obviously, if anyone's with us for more than a couple of months, then it's very easy for us to slot them into the regular training sessions that we've got, and they're staying with us for that sort of period of time. Much harder for me, to be honest with you, to get that training put in place if someone's just coming for a couple of shifts in a week. But again, I can ensure that they have had their training external to here, and it is a requirement of all doctors to be compliant in safeguarding for both adult and child anyway. And so that's the medical side. The nursing side, again, same sort of things. There's a requirement in the General Nursing Council as well that the training is being put in place, so we can ensure those people have met that if they're coming from an agency or from a locum background. But it's something I take your point completely on this, Jim, that these things happen and then they drift away over a period of time. This can't. This is one of those that actually this is here to stay, and we need to completely change the culture so that we will always be thinking about this. Even in 10 years' time, I'll be able to assure you that we're up to date on what our compliance is going to be. This is going to be a long-term impact. This is going to have this case on us all, and quite rightly so.
Thank you, Dom. Thank you, Chair.
Thank you, Dom. Thank you, Jim. If I could invite Paul in, please.
Thanks, Chair. It's just responding. Linda's put a point in the sidebar there about how we can assure ourselves around psychological safety point for staff, and I was just thinking it's perhaps something we can pick up in the IM and exec safety walkabouts. It may be that this might be a topic when colleagues are doing visits to different departments, perhaps a question or discussion with staff about do they know how to go about raising concerns generally, and do they feel comfortable in raising concerns, whatever concern that might be, whether it's about an individual patient in terms of the issues that Don was just describing, or indeed any other concern. So I just think it might be worth, and we can pick that up, Linda, in terms of the prompts that we provide to IMs and the execs when they're doing those walkabouts. I think that's a good sort of test that we can bring in place to see how we can assure ourselves collectively as a board that those sorts of things are happening in our organisation.
Thank you for that, Paul.
Can I just come back on that? This is, it's exactly as Paul's saying, that there's no one way of tackling how we flatten the hierarchy, and that's been one of the major concerns, that if someone senior's made that decision, you can't question it, and that's what we need to eradicate. But there's no one way of doing it. So I think what Paul said is fantastic, and that's one way to do it. The other one is ensuring that there's an escalation plan in place. The other way is actually me in my role is saying to consultants, you should be prepared to be challenged on this. You should have it as a discussion. This isn't a one person makes the decision point, but there's so many points to it that we need to pull in to make sure that we flatten that hierarchy.
Thank you, Dom. So just from my perspective, listening to Jim's earlier questions and comments, is that I suppose MDT working, team working as a learning for us all really is that, and certainly in this terrible situation, is that it's about how we include that as part of our, I suppose, the bigger development across the health board, but also how we include it in our induction packages as well when people come to work within our organisation. And I'm sure some of that's already been thought of, but it's okay. Are there any other further questions? No, and there is a point I know that Nicola wants to raise, but I know that Hal will be raising it under the staff survey. Can I just say to you, Don, one other question for me is that obviously I note in your presentation that we've got an action plan in place and it's been monitored through the QM Quality and Safety Committee. I assume there's a link to the Cwmtach Morgannwg Safeguarding Board as well in respect of that too.
Yeah, they're very closely monitoring what we're doing, and we're reporting on to them as well as to what the action plan is, and also all the steps that are being asked specifically have a report going to them that we've addressed everything that's come up in the previous report as well. So yes, no, we're making sure that we're the other part to this. So I should apologise for taking this longer. There was a big question about interagency working. This wasn't just us, how we interact with the police, how we interact with the local authority, and so that report will then be circulated amongst all of those groups involved as well to show that we are making those changes.
Thank you again, Dom, for your report to the board of a very sad and sensitive situation. So can I now move on to the next item, please, which is the 5.6, which is the Maternity and Neonatal Improvement Programme report. I'd like to invite Greg Dick to present the report, which was discussed at the Quality and Safety Committee on the 24th of January 2023 and is before the board for noting. Greg is also joined by Sarah Fox and Mohammed Ainashati, who will assist Greg in presenting the report. Greg, if you could lead, thank you.
Thank you very much, Chair. I'm just going to top and tail the report. So just a reminder, which Matt mentioned earlier, we have now de-escalated from special measures to targeted intervention. So we're in phase 2 of our improvement work for maternity and neonates. Some of the remaining initial RCOG recommendations are now within our refreshed improvement plan, which the team will go through in a little while. One of the very early recommendations was around ensuring that clinical leaders attend board committees to ensure that their voice is heard, and that's exactly why both Mo and Sarah are here today and also were at the Quality and Safety Committee on Tuesday, as opposed to just myself or Dom presenting the report. So I'll hand over to Mo and Sarah, Chair, if that's okay, and then I've just got a few words to say then at the end of the presentation. So thank you very much both.
Thank you. If I could invite Mo and Sarah in then, please.
Thank you, Chair. Thank you, Greg. So I will quickly through the report. So our improvement journey started in 2019 and really would like to offer our sincere apology to the families who helped us through that journey. Till the Welsh Government announced that maternity services were removed from risk measures. Our work was mainly around safe and effective care, quality of human experience, quality of leadership and management. Our priority at the moment is to ensure sustainability of what we achieved, to ensure that we learned from our experience through that 3.5 years, and to ensure that all the improvements which happened through that 3.5 years are safe and sustainable. And we developed that through our own assurance board meetings. So now we have our maternity and neonatal assurance board, we have service-wide assurance group, and we have our care group assurance meeting. All of these groups are essential to ensure that the information has a clear channel of flow from floor to board, and there is a clear channel of communication between our colleagues on the first shop floor and the exec team, and ensure that there is high level of scrutiny for service provision provided by the exec team, as these boards are either chaired by Greg and Sally, like Maternity Assurance Board, or chaired by the care group directors in the care group assurance board. What I would like to bring to the highlight today is about the gynae pathways, all the improvements around maternity. However, gynae wasn't forgotten. So we managed to develop a standard of service provision for emergency service to ensure that women attending through the emergency department with early pregnancy or emergency complication has a clear set standard of care of provision for them to ensure safety. We have a dedicated gynae emergency units across the 3 sites. So we have 24/7 emergency gynae unit developed in Prince Charles Hospital. The announcement of it open was in last year around August time, and it showed clear improvement in the waiting times, almost 2/3 saved of waiting time for the woman with a dedicated care. We also developed a dedicated early pregnancy unit in Prince Charles Hospital, and a couple of months ago we managed to create a dedicated ASU in Prince of Wales Hospital, which worked 12 hours, 5 days. Other points around gynae service improvement is around development of gynae hub in Rondetafili, and that gynae hub will serve the woman around in Camtaf Morgano, and it will include one-stop services, scanning, and a wide variety of clinics, which will help in improvement in our cancer performance, which already jumped from around 0.20% to 40%, and we are going to achieve almost around 65%, and will help to achieve our recovery plan as well. For neonatal improvement, initially it was running at a slow pace, but now is running at a good acceptable way. We have developed our in utero transfer pathway, which was agreed between obstetrician and neonatologist, and the care group structure helped in achieving that, because now we are all one happy team and one happy family, which is running together around that. And that in utero transfer will ensure that women first with preterm labors who are less than 32 weeks are delivered in the right site with the right team, and if need to be transferred, there is a clear pathway for that transfer. We managed to get the hypoxic encephalopathy pathway in action, as well as we have a clear structure now around serious incidents, which are now reviewed in local MDT followed by senior MDT, and if the RCA indicated, it will be developed through assurance and closure panels. Another improvement is using data to achieve improvement. So now we are data-driven services. So we developed our maternity and neonatal dashboard, which contains all data required, and that dashboard is reviewed on regular basis through the forums. And we based our learnings through the data with that and how we can improve service. We have our PREMS, which is a patient engagement. So we collect all data from women engagement through different channels, and we use the data to achieve our improvement in services. We have our integrated dashboard, and we have the graft recommendations, which is running through the gynae pathways to improve gynae services. We have our maternity wash-up plan now. So following the release of the Welsh government that the health board can be released from the risk measures, there were quite a few actions left to be done. And these actions now are done through the maternity wash-up plan with the scrutiny from Maternity and Neonatal Assurance Board. The first one was about the RCOG recommendation, which is a woman admitted to emergency department with emergency gynae or early pregnancy complication is to be seen within 12 hours. The current version is we are within 18 hours. To achieve that 12-hour as an ambition for all health boards. So we had several meetings with other health boards across Wales and even with other clinical directors in United Kingdom and England to look at that window. Most of us are not compliant with 12 hours because the safety workforce, which came from Royal College a long time ago, doesn't take that into recommendation, and this was escalated through the safety channels. Also, it's an aspirational. I can assure the board now there is no risk or incident was raised because of that 6-hour not compliance. We are all running within the 18-hour compliance at the moment. We have 2 teams for ops and gynae, and if any emergency patient requires urgent attendance, the consultant is available. If not, she has the admission, she has the care which is needed, and will be reviewed as next day in the morning. We also have our QI training, so the quality improvement training now is achieved in-house, and we have developed several days now for our staff, which is running as an MDT between obstetricians, neonatologists, midwife, and nursing. And we have quite a few projects running. One of them was the maternity and neonatal dashboard, which happened as an example of that QI training. Other projects happening now is an Attain and Pistos, which is mainly about triage of women attending through emergency for maternity, and it includes the MDT approach. We have our maternity and neonatal safety visit, which happened in the first visit happened about 2 weeks ago, and we had a very positive feedback from that visit, and we are engaging with the All Wales Maternity and Neonatal Safety Program to achieve the improvements required. Our training compliance now is improved quite a lot, and now are around 95%, and we had clear channels of neonatal engagement. For putting things right as I complain, I will hand over to my colleague Sarah.
Thanks, Mo. I think that was very comprehensive. I have nothing to add, but happy to support in any way after Greg has closed the paper. Thank you.
Thanks very much, Sarah, and thanks very much, Mo. So hopefully board colleagues can see that the improvement work has definitely continued and moving in to this next phase, particularly with a focus on closing down the remaining neonatal deep dive actions and being fully engaged with the National Maternity Neonatal Safety Support Programme. Appendix 1 of the report sets out our agreed maternity and neonatal assurance risk and escalation framework, version 5. There's been lots of work in this regard, and it was finally validated by IMSOP before they left last year. And finally for me, and it's I'd be keen to get a view from the board in relation to whether the board will be satisfied for Quality and Safety Committee to continue to govern the delivery of our improvement programme, and future reporting here will be by exception only. So that's it from me. Thank you very much, Chair.
Okay, thank you, Greg. I'd like to invite any questions that any board members have, please, for Greg and the team. Jane?
Thank you, Chair. Just want to reinforce what Greg has just said. Quality and safety continues to have a big role in scrutinising delivery of the action plans. We had further detailed reports on Tuesday of this week. And let us not forget that I also attend the Maternity and Neonatal Improvement Board as an independent member. And that board is very active in reflecting on practice and ensuring that improvement is delivered. So if board colleagues are supportive of the proposal, I would assure you that Quality and Safety will continue to have eyes on the action plans. Thank you.
Okay, thank you, Jane. I'll confirm that in a second. If I could just invite Jim in, please.
Thank you, Chair. In relation to the report, some very encouraging work has been achieved. Bear in mind it's a public meeting. How confident are we that the improvements that we've made to date are sustainable going forward, bearing in mind the difficult financial situation we face, certainly the next financial year or so?
Greg, do you want to come in to respond to that?
Yeah, of course. So throughout the improvement journey, Jim, we've been ensuring that the conditions for sustainability going forward are embedded within practice. And you may recall, as part of our roadmap to de-escalation, we needed to provide evidence both to this board and to Welsh Government colleagues and our regulators that the conditions had been achieved, and we have a mechanism now to sustain those. So the maternity and neonatal assurance framework as set out in the appendix will or should provide board colleagues with the assurance that the improvements we've made to date will continue and will enhance as we move forward. Regrettably, you know, there will be complaints and there will be serious incidents in the future, but we're definitely in the pack now, if not better than some of the other organisations in relation to our process and outcome measures of quality and safety. And the processes we now have when a complaint or a serious incident occurs, as Mo's just articulated, is very much dealt with in a different way from a multi-professional perspective. The neonatal remaining work will be a challenge, and there is some work currently undergoing, being led by the Children and Families Care Group in relation to a workforce plan, particularly for neonates, but also an opportunity now where the new care group, being responsible for the entirety of children and family services, can do something much more in relation to how the workforce is managed across the 3 sites. So it's we've worked so hard in the nearly 4 years on this improvement programme, and please be assured that all of us that have been part of this will absolutely not keep our eye off the ball, and certainly now with the leadership teams we have in place from a children and families perspective, I'm very confident now that they will pick this up and ensure that the improvements become business as usual. So I don't know whether Sarah or Mo wants to add anything to that.
Thank you, Greg. I would like to assure the board about our process in reviewing any complaint or incidents. As you all know, in obstetrics and in neonates, unfortunately, complaint will happen and incidents will happen because the nature of the job. But the way we learn it from it and the way we review it is different from what's happening before. So now for any complaint or incidents happen, if it is serious, we'll start with the rapid review, and this rapid review starts within 48 hours of the occurrence of the incident with a senior team. Following that rapid review, we have a weekly local MDT meeting where discuss all the incidents which happened through that week, and that local in each site. So we have one in Prince Charles and one in Prince of Wales, which include obstetricians, neonatologists, midwife, governance team, and anesthetist. And then following that, we have a weekly senior MDT meeting where all the incidents which have been discussed on the local one with the learning from it are shared in the senior MDT meeting to ensure another layer of scrutiny. And then if any incident qualified to have a root cause analysis, it is done and then closed through our assurance and closure panel, which happen on monthly basis. But more important is how we share the learning to ensure that this incident will not happen again. So we have different channels for sharing that learning, starting from immediate make safe, safety briefing, one-to-one discussion, whether through the senior midwifery or through the obstetric leads and clinical directors. And we have every week a care group newsletter, which include all the incidents to be shared across. So our process is completely now robust, and we are ensured to maintaining it to ensure that any incidents happen, we know it, we study from it, we learn from it, and we share it between all the team to avoid its recurrence again.
Thank you, Chair. Thank you, Mo and Greg, for coming back there. I think the public observing this meeting today, I think would get a clear sense that this is something that you've all taken very much to heart. And I endorse what Jane said earlier, as I sit on quality and safety, and we keep a close eye on what's going on as well. Thanks very much.
Are there any further comments or questions you want to ask before I send this item out? No. Okay. Noting Greg's request and the presentation that was made today, the update on the action plan and the controls that are already in place. Also noting our colleague Jane, who's the chair of the Quality and Patient Safety Committee and also sits on the Maternity Neonates Improvement Board. Can I just confirm with board members, are we content, or are there any objections that anyone wants to make, that the progress going forward remains with the Quality and Patient Safety Committee, and any exception reporting will come to the board? I just want to, easier for me to ask, are there any objections to what's being proposed? No. If no objections have been proposed, can I just confirm then that we are content that of the proposal of the progress being monitored through the Quality and Patient Safety Committee, and any exception reports will come to the board?
No objections received, Chair.
None at all. Okay, thank you, Wendy. Thank you, Greg. Thank you, Mo, and thank you, Sarah, for your presentation today. Can I just now, I was going to suggest a break, Howell. Is that for 5 minutes? Is that okay with everyone? Can I just suggest that we take a break for 5 minutes? It's now 28 minutes. So we get back here by 25 to 1, and then I'll invite Howell in for the next part of the board meeting. Can I also suggest that you turn off your cameras and mics, please, for these next 5 minutes? Thank you. Okay, can I just check with Wendy that everyone's back in the meeting, please?
Yes, we seem to have lost Geraint, but we're trying to get him back, but I think you can proceed.
Okay, thank you, Wendy. Okay, welcome back to the next part of the board meeting, please. And we're on to item number 5.7, which is the turnover position and retention plans. And I invite Howell Daniel to present the report, which is before the board for noting. Howell.
Thank you, Chair. So just to give a bit of background to this and to remind board members of where this piece of work came from. So we've had a short discussion at our last board meeting in relation to turnover figures and some trends in turnover figures. This is a briefing to update on that position. It isn't a substantive board paper at this point, and a fuller paper is going to the People and Culture Committee in February. So what this paper seeks to do really is to update and apprise the board of our current position in relation to turnover. We can't have a conversation about turnover without having a conversation about retention. It looks at a little bit of the data and highlights some of the limitations with the data and what we need to do to get underneath the bonnet of some of the data to a greater extent. And then also highlights the national Welsh picture and UK picture in relation to turnover to give a little bit of a benchmark. And then also reminds of some of the activities that we're currently undertaking, but some of what we plan to do further from this point onwards. So you'll note from section 2 of the paper that our current turnover level in CTM stands at around about the 12% mark. It might vary between 12, 12.5 and down to 11.5 some months, but broadly speaking, we're around about the 12% mark. That is shown if you look at the very top of the table on page 2, so where it says rolling 12-month turnover, we have seen a fairly linear increase in turnover since 2018, but for one period during 2021 where in the middle of the pandemic, turnover and predominantly retirements slowed down from normal levels. So we've reached a high in relation to our turnover rates. Below that then gives you a bit more detail in where that's occurring, and pretty much in all of our staff groups, with the exception of healthcare scientists, we are seeing an increase if we look at the crude data between 2021 and 22. As I mentioned at the last board meeting, and this was something I think we were all quite concerned about, there are some trends in turnover by age and by career length, which is interesting and something we need to do further work on to understand. Now, in some groups that might be normal. So, for example, in administrative roles, it's quite common actually to see people move around and jump from one role to another at the beginning of their career. That tends to be a pattern. People do tend to stay in roles for longer as they become more senior or towards the end of their career. However, clearly where we're seeing that in professional settings, that's something we need to delve into further. And what we need to understand very clearly is whether they're going on to other roles and then coming back to us, or whether they're leaving the profession entirely. And you will probably know from having seen it discussed at national level on the news that there is a trend at the moment across the UK where people are entering the professions, particularly nursing and medicine, and are within the first 3 to 5 years of entering the profession are moving on to do other things, whether that's work abroad or move into different sectors. So we need to understand that data better for ourselves. The other thing I just mentioned is around reasons for leaving. So there are limitations of this data. So broadly speaking, across the entire workforce across the UK, not just the NHS workforce, the main reason for leaving a role is usually cited as relationship issues with managers. Now, we expect an awful lot of managers. That doesn't feature within our top 3 reasons as it does in other sectors. However, we should note that these reasons are taken from termination forms, which are more often than not filled in by managers. So we do need to consider that when considering these reasons. However, the top 3 reasons that we've got are around work-life balance, which is clearly something that we should be concerned about. Promotion, which can be a good thing, but again, we need to make sure we're creating opportunities for people internally so that they're not continually leaving us to take up opportunities elsewhere, and the same in relation to relocation. So just touching on the national and local context. So mentioned here that the range of turnover rates across Wales ranges from around about 10 to 14%. Looking at our October data, and you see that our percentages come down a percent or so even within 2 months of this comparator data. So the data is fairly flexible, but we were in amongst that pack and the second highest in October, but obviously that's come down to 12.7% in December. But the range is quite significant, and we are around about in the middle of the pack there for October and December data. And then in terms of English data, the macro level figure for the whole of NHS England at the moment is 12%. And I remember looking at that rate in previous roles I've been in, and it used to sit at around about 8%. So that should give you a bit of an indicator there of the increase. That's a 50% increase over probably the last 4 or 5 years, which if you look up at the data I took you through on page 2 mirrors our data. Now, the reason we're giving you this context is not to say it's a national problem, therefore we can't do anything. That isn't the case. There are clearly actions we can take locally to minimise turnover, and that's where we come on to the discussion about retention. We are not starting from a zero baseline here, so a lot of the work that we do and have done over the last couple of years really is focused on retention. So the employee experience work that we do, which is focused on giving each of our 13,000 people the best possible experience that we can, that is a retention activity. The work that we do on well-being and the development of our well-being offering, noting some of the issues that we've got in relation to pressure and burnout within our workforce, is a retention activity, as is the work that we're doing on developing leadership and management. However, we've clearly got more work to do, and what we plan to do is to focus our attention to a greater degree, and that starts, I think, with understanding the problem to a greater depth than I think we currently do. Our data is very high level. We currently have an exit process that works for us, but doesn't work for the people who complete it. So in that sense, it's flawed, and we are launching a new exit process in 4 days' time, which hopefully will improve the data that we get. I'd also say that we need to get much better at trying to have these conversations with people before they've decided to leave. Because there are, and the evidence suggests that there are opportunities to intervene to resolve issues, whether that's by having a conversation with individuals or giving people the opportunity to move around internally within the health board. So we also need to get much better at doing that. So the proposal is to pull together the good work that we're already doing, take a look at the best available evidence in this space, not just from healthcare but other sectors, but also to look at who does this really well. There are also some really good pieces of work that have been driven nationally, both within NHS Wales via HEIW, in NHS England, and also the Royal College of Nursing has done some really good work in this area to analyse what would have an impact on turnover and retention. What we need to do is pull that together into a clear plan. We then need to take an improvement approach to monitoring that plan, what's working, what impact it's having. If it's not having an impact, we move on, we try something different. If it is impacting, we scale it up, and we make sure we maximise the impact across the health board. What we will then do is set up a group to steer that work, whatever we end up calling that, but essentially a steering group for retention, which will take oversight of the breadth of this agenda, including workforce planning, which itself is is a retention activity, and then that will be reported through via People and Culture Committee. This isn't just about nurses. However, our initial focus, I think, will likely be on Band 5 registered nurses and HCAs, because I think that's where we've currently got the most significant issue in terms of vacancy levels, but also driving some of our cost, and also focusing on some of our other metrics such as sickness absence. So we will focus on those areas initially. And also what I'd say is some of this is now manifesting in terms of what's being highlighted by some of the industrial action and pay issues, insofar as we are also quite worryingly seeing lower take-up of training places. So we've got a real issue here. It plays into a national workforce issue, but there are things that we can do better locally. So this is intended really to update the board on that plan and the position. And I'm asking the board, to note the contents of the briefing, and then to note the approach to developing the steering group and plan. Thanks, Chair.
Thank you, Howell. I invite board members to raise any questions or comments. Nicola?
Thank you, Chair. Thank you, Howell. It's just a quick comment really to say that although this is in the early stages, Howell's team and Greg's team have also done quite a lot of work to start, and some scoping exercises, and there's been some excellent working in partnership with trade unions as well. So there's a lot of involvement to take this really excellent issue forward.
Thanks, Nicola, and yeah, just to say the kind of opposite end of that, really, to thank trade union colleagues for their support and their input and their ideas in this space as well. Thank you.
Thank you very much, Nicola, and thank you, Howell. Can I just confirm with Wendy, are there any further questions or comments or objections, please?
Nothing further, Chair.
Okay. Thank you to Howell for presenting the report. In conclusion, the board resolves to note this report. We'll then go on to item 5.8, please, which is Digital and Data Committee Highlight Report. I invite Ian Wells to present the report, which is before the board for noting. I invite Ian to present the items identified in the Alert Escalate section only. Ian.
Yeah, thanks, Emrys. We're not going to keep you long. It's only a couple of points which we need to highlight. The first one is the committee had a report from Grant Thornton, and that was regarding the clinical information review. We felt we needed to highlight this to board because they identified in that report capacity and resource issues in the digital and data team, which potentially would impact the delivery of the information improvement plan. We are going, or the execs are going to take this, however, into the integrated medium-term plan, and so hopefully it'll be resolved when it gets to that stage. But it was just making the board alert the board rather for that at the moment. The other thing that we wanted to raise is what we call a positive escalation, which is something of good news. And members of the board will know that over a long period of time, over many years, in fact, and we've had problems with clinical coding, and members have raised questions related to clinical coding because of performance in that area. And this is a really good news story, really. We were audited by DHCW, and they did a coding audit of the work that we were doing. And members will be pleased to hear that we surpassed the minimum coding standards of 90% for primary diagnosis and primary procedures, and 80% for secondary diagnosis and secondary procedures in all localities, which is a massive improvement on where we were previously. And the reason we are highlighting this, not just because it's good news, but because the reason that was possible was because the team that are working in that area developed innovative technology that hasn't been done anywhere else. Certainly in Wales, I'm not sure if it's been done in the UK, but it's something really that the board can be proud of, and something that we need to be shouting from the rooftops about, and really congratulate the team for getting to that level.
Well, thank you for that, Ian, and it's really good news to hear the progress we made in clinical coding, and certainly noting your comments about how well the team has done to achieve the performance that they've done. So well done to all there. I can see Stuart wants to come in, so I'll just invite Stuart in on this as well then, please.
Thank you, Chair, and thank you, Ian. And just 2 brief points really in response to those escalations. And absolutely, in terms of the first point around resourcing and and capacity, I think that's, as we've heard throughout the morning, in terms of some of the challenges operationally and clearly our financial position going forward. So while board members will remember, at the moment I'm currently setting the foundation with my strategic leadership team structure. And then what we're planning to do is align our data needs very much alongside those top priorities for the organisation as we move forward with our plans into next year. So conscious that there's a lot to do and there's a lot of demand on data and digital services right across the health board, but clearly we need to prioritise, and that may mean we need to make some tricky decisions on how we resource certain elements. So acknowledging it's a challenge for us all, I suppose, at the moment. And just picking up on your positive escalation, yeah, it's fantastic the way in which we've developed this auto-coding, and you are correct, it's not being done anywhere else in NHS Wales at the minute, and indeed a number of the health boards now are coming to us to look at how they can adopt that technology within their organisation. So really encouraging story, and it actually ironically does cover off a resourcing issue, because we know that clinical coding resources are a challenge, and actually a skill set that is in high demand and low supply. So this is an area where we've now used positive use of technology and automation to bridge that gap in capacity that we wouldn't have even been able to recruit anyway. So it's good news.
Thank you for that, Stuart. Again, thank you for the confirming the positive work that Ian has identified in relation to the auto-coding, and it's good that we're in a position to share some of the learning with other health boards across Wales. Is there any other comments or questions or objections that anyone wants to raise with Ian from this item? Wendy, can you confirm?
Nothing further, Chair.
Okay, thank you. Can I just say thank you, Ian, for presenting the report. The board resolves to note this report. Can I then go on to item number 7.1, please, which is the CTM 2030 strategy? And can I invite Linda Prosser to share a video presentation with members, which is before the board for noting. Linda.
Thank you. The board will remember that we approved some time ago our overarching strategic goals and the activities that we wanted to undertake in order to develop and deliver a strategy. We made a decision that we didn't want to produce a big document that would sit on a shelf. We thought long and hard about how to make it accessible, and want to propose that what we actually produce is a series of videos whereby we have talking heads and other footage that describes our approach. And rather than making one big video, we think that that should be a suite of clips that can be updated as things get developed and can just be wholly accessible to people. So the first one, which I want to show you now, is only 3 minutes long, and thanks to Simon Blackburn and the comms team for getting us to this point, and to those who have agreed to speak in here. I think this, I kind of commend this short video to you as a neat kind of overarching presentation of what we're trying to achieve as a organisation. Let's have a look at it now, and then I'll explain how we'll develop that with further videos and what we're going to do with it, and get your comments.
Hello, I'm Paul, Chief Executive of Cwmtaf Morgannwg University Health Board. Welcome to this short film to introduce CTM 2030, our strategy for building healthier communities together. CTM 2030 sets out ambitious aims to provide our population with the best possible care and experience by working creatively, collaboratively, and with compassion. It will empower people to live better lives and enjoy greater control over their health and well-being. We created our strategy with our staff, our partners, and our communities, and we will continue to work alongside you as we develop a modern health and care system of which we can all be proud. Let's see what the strategy looks like and then hear what it will mean for people. Working with its partners, including organisations like Age Connect, the Cwmtaf Morgannwg Health Board will provide people with support to help them live more healthily, more happily, regardless of where they live or who they are. Together, we will help to ensure communities have access to the services, information and support they need to take control over their health and well-being and avoid preventable illness.
We will remove barriers between services and different organisations, making it easier for our teams to make decisions and provide people with swift access to the care and treatment they need. We will be innovative and ambitious in meeting the needs of our local communities, ensuring our staff feel proud to be part of CTM Health Board.
We will ensure staff have access to the training, support and technology they need to provide the care and services they aspire to. People's opinion, experiences and ideas will be heard and valued and will help us to continually improve as an employer and a provider of care.
We will be aware of the impact that our services have on the environment, and we will work hard to make our buildings and our activities as green as possible. We will be champions of the local economy, celebrating the skills of the people and the businesses that make up our communities. Working with educational partners, we will support local people to develop exciting, fulfilling careers as part of the CTM team, creating a diverse international workforce in which people can be proud of their heritage.
So the next step, with the intended next steps, that we then create further videos, particularly, so for instance, one that goes deeper into community resilience and our work with voluntary sector that Rachel described there, perhaps linking it to some of those WISE activities in the film that we've seen earlier. One that says more about our ambitions around the green agenda. And then quite a few, I think, that are more specific about services. So how we're working to create integrated out of hospital services, primary care, etc. But how we're looking at reconfiguring some of our acute hospital activities and services as well. And I think another one on the sort of whole people agenda that we've heard. So I think and then, you know, as we can build it up as we develop the activities and plans and keep people up to date with what's happening in that space. So that's the suggestion, and that's where we've got to. And yeah, people have got comments or questions. Oh, I did meant to say, sorry, Chair, that we did just road test this with the CHC full council this week, and it went down very well. They got the message about, you know, they were very keen on the message about supporting people to be healthier at home and, you know, take care of themselves. And there were any questions about how we disseminate that. And my sense is that we'll just get a few more up there before we actively publicise and push out.
Thank you for that, Linda. I just invite any board members to raise any questions or comments in what Linda's just shared with us. I can see there's a couple of comments here on the sidebar about the great video, like the way it's structured and partner staff can use in front of the camera. You know, a refreshing approach, you know, and will reach a larger audience than a paper, and like the iterative approach, it will be more topical and up to date. So some good positive comments there, Linda. Are there any other comments that anybody would like to, or questions anyone would like to ask of Linda in respect of what's just been presented? No, and just to confirm with Wendy, just that can you please confirm if there are any remaining questions or any objections to what's been shared?
Nothing further, Chair.
Okay, thank you for that, Linda. I then go on to item number 8, please, which is any other business. And I've got one item, and I know that our colleague Sally Bolt would like to give us an update on the clinical advisory group. Sally. So you're on mute at the moment, Sally.
Oh, I am. Somebody has to do it. Unfortunately, it was me on this occasion. Thank you, Chair. We had the initial meeting yesterday of the newly renewed clinical advisory group. We've got a very wide participation from a number of the clinicians across the health board, so not just medical and nursing, but also various other health scientists and health professionals and therapists. We discussed the new care group structure, and overall a very positive response. There's a bit of a request for an update on the next phase of development, which I'll pass on. And we also mentioned about the digital transformation and the plan to sort of coordinate rollout and of any digital solutions, and also the full integration with Bridgend. And the representatives of the group are going to go back to their teams and find examples of solutions that can cause improvements in efficiency and patient experience. For example, smart products which can enable dementia patients to stay safely at home for as long as possible. So that's a brief summary, because I said it was just the first meeting, but I think the other thing we discussed after the original introductions was sort of the remit of the group to sort of facilitate two-way conversation between the wider clinical body and the board. So I'll leave it there. Thank you.
Thank you very much for that, Sally. And I've got one comment coming in from Paul. Paul?
Yes, thanks, Chair, and thanks, Sally. I think it's really good to see this group being refreshed again, and with a broader range of clinical colleagues alongside Sally. One of the challenges was trying to get that breadth of input from the experience. I guess there's also something, Sally, as well as the opportunity to feed up from this group up to the board. It might be interesting perhaps for IMs, if they were interested, to perhaps come along to a future clinical sounding board to feed back down to clinical colleagues as well, just to try and sort of get that sort of network of contact across the organisation. So I guess I've just put that out there, and would any IM be interested, and if they are, I guess Callie can help coordinate with you, Sally, about how that would work in practice.
Yep, absolutely.
Absolutely. Well, thank you for your item there, Sally, and thank you for Paul for his comments. I can't see there's no other further comments. If I could go on to item 8.1, please, and that is, how did we do in this meeting? I refer board colleagues to the comments regarding this item made during introductory remarks at the beginning of the meeting, which I asked you to bear in mind. I therefore invite board colleagues to put forward any comments for improvement at this point or within 2 weeks of this meeting. And it might be easier, I suppose, if any comments you do have to make, is you could share them outside the meeting as a consequence of time. Thank you. Can I then go on to item 9, which is date and time of the next meeting? The next scheduled meeting of the board held in public will take place on the Thursday, the 30th of March 2023, commencing at 10 o'clock. And in the close of the meeting, rydw i'n dod â cyfarfod o bwrdd iechyd I ben a hoffwn I ddiolch I bawb sydd wedi ymuno a ni a gwylio'r cyfarfod heddiw. I now bring the board meeting to a close and would like to extend thanks to all who have participated in the meeting and or observed proceedings today. Please note that we will be holding an annual meeting of the trustees at 2 o'clock this afternoon. Okay, thank you very much all.